Good morning, everybody. Welcome. My name's Raj Jain. I'm the chair of the Integrated Care Board for Cheshire and Merseyside. Firstly, thank you to people at Runcorn Town Hall for accommodating us in such a fantastic building and surrounding areas. I'll just let our members of the public come and have a seat while they're finding their seats. I just want to say a hearty welcome to members of the public. This is a meeting in public, and what that means is we don't have a facility during the formal part of the meeting to interact with you. You need to sit and listen. However, what we try and do at the end of the public meetings, if people want to speak to us, we'll have the officers or myself will come and speak to members of the public on issues. In that way, we'll try and get some good interaction with you. I'm hoping you find the formal part of the public meeting interesting. There's some stuff that you might think, well, I don't want to listen to that because it's formal business type of stuff, but there's some good stuff here on the agenda today. So, I'm going to go round the table and ask excuse me, people to introduce themselves first. I'll start at this end.
John Llewellyn, Chief Digital and Information Officer.
Good morning, everyone. My name is Anthony Middleton. I'm the Director of Performance and Planning.
Good morning. Ian Ashworth, Director of Population Health.
Good morning. Fiona Lemons, Associate Medical Director for Transformation.
Good morning, everyone. My name is Adam Irvin. I'm a Primary Care Partner Member from Pharmacy.
Good morning. I'm Claire Watson. I'm the Assistant Chief Executive at the ICB.
Good morning. Tony Foy, Non-Exec Director.
Hi, I'm Claire Wilson. I'm the Finance Director for the ICB. Hi, Louise Merger. I'm Corporate Governance Manager for the ICB.
Good morning. My name is Graham Irwin. I'm the Chief Executive of the Integrated Care Board.
Good morning. I'm Anthony Leo. I'm the Place Director for Halton.
Good morning. I'm Hilary Garrett. I'm Non-Executive Director.
Good morning. I'm Joe Rafferty. I'm a Partner Member for the Mental Health Community and Learning Disability Collaborative. I'm Chief Executive of Merseycare.
Hello, I'm Chris Douglas, Director of Nursing and Care at the ICB.
Good morning, I'm Neil Large, Non-Exec.
Good morning, I'm Chris Smith, I'm the Chief People Officer.
Hello, everybody. Councillor Paul Cummins, Cabinet Member for Adult Social Care in Sefton and Partner Member for Local Government on the ICB.
Good morning, my name is Erica Morris, I'm a Non-Exec.
Good morning, I'm Rowan Pritchard-Jones, the Medical Director.
Morning, I'm Naomi Rankin. I'm Primary Care Partner Member and General Practice.
Sally Yeoman, Chief Officer at Halton and St Helens Voluntary and Community Action, and here for Cheshire and Merseyside's voluntary sector.
Are there any declarations of interest that have not been made to date, matters pertaining to the agenda? No? Okay. Minutes of the previous meeting. Can I take any matters arising or corrections at the same time before I move to seek the board's approval for those minutes? Any matters arising or corrections? Happy that it forms a true record of the meeting. Yeah, thank you. So we'll take those minutes as being agreed. Let's go to the board action log. You'll see it's here for noting. Are there any updates or corrections if you want to make to the action log? No. I will make an overall comment. It's growing in length, and it'd be good to see some progress on closing off some of these actions. And we'll come to that in future months. And very importantly, the board decision log is there again for noting, but if there are any inaccuracies, please do shout out. Okay, duly noted. Let's go to Chair's announcement. I've got a couple of things I wanted to say this morning, and I think we all know, don't we, that on the 5th of July, the NHS is 75 years old. And as I was writing some notes to think through what I was going to say this morning, I felt it's not a long time since the NHS was 50. Back in 1998, and I thought, that seems just a short while ago. But here we are on the 75th anniversary of the NHS. And many of us believe that the NHS and its principles are one of the most important things that this country has ever achieved. I'm enormously proud to be working with and for the NHS, and I'm sure all of us are. And the NHS, it's a system that guarantees healthcare. It's nationally organised and it's publicly funded. Those principles are hugely important to us sat around the table. We know times are tough and that NHS staff are under enormous pressure. But we do want to take the time to celebrate this really important anniversary. And much has been achieved, hasn't it, in the last 75 years? There's been notable world firsts, and I won't list those. But what I do want to call out is that every single day, every single hour of the day, there are thousands of interactions, thousands of contacts in which NHS staff, patients and their carers feel good happens, feel really cared for, and feel that we're trying to make a huge difference to those people's lives. And that's what I'm really proud of. It's good to see the world achievements, isn't it? But it's the long, hard slog of those many, many interactions, many, many care moments that happen day in, day out. Millions of them, even in Cheshire and Merseyside. So, expectation from me is that when it's NHS 100 in another 25 years' time, which will go up like that, I guess, as well, we may not be sitting here, people will take over from us. We'll be sitting here thinking, wow, what another 25 years of greatness from the people of the NHS. So, just a time to reflect, and I guess for many of you who've worked long and hard in the NHS, and for many of you who've worked alongside the NHS or been treated by the NHS, it's a time to celebrate. I also wanted to mark the 75th anniversary of HMT Windrush landing at Tilbury Docks on the 22nd of June, 1948. So it's a coincidence, isn't it, of 75 anniversaries. And the anniversary may well have just be a coincidence. But it's no coincidence that the success of the NHS is intimately linked to it having a diverse workforce. The NHS is actually the largest employer of black and ethnic minority people in Europe. Some 24% of our staff come from that background. And I know our leaders, our organisations, and our staff and patients owe a great deal to those people who gave up so much to come here and support the NHS, and who continue to do so. So thank you to those people. And lastly, I wanted to mark the first anniversary of the ICB. We inherit this stewardship of a great institution, and along with our partners, we're charged with making care services more relevant to the needs of our citizens and patients. It's been a hard first year of establishment, but there are many good things that are getting started. And I look forward with optimism and belief that the staff of the ICB will play their full part in transforming care services and supporting the well-being of the citizens that we serve. Thank you. Thank you. So if I can move to the report of the Chief Exec.
Thank you, Chair. First thing I want to do, ladies and gentlemen, is just acknowledge the tremendous efforts that's been made once again by a whole range of staff, frontline staff, managers, everybody behind the scenes that has successfully negotiated the last range of industrial action that the NHS has seen. I have called out within the paper today the number of operations and procedures that were cancelled as a result of this industrial action. I have to say, I think that's a massive understatement of the impact that the industrial action has, because actually our hospital managers are just not booking patients on days when they know that the strike is forthcoming. I think it's of great credit that services have been kept safe, but people will know that this weekend the ballot of the Royal College of Nursing was announced, so we are not going to have any further industrial action from nurses, certainly not for the next 6 months. But we do know that we still have a range of further industrial action from both our junior doctors, but also our senior doctors. So I just wanted to acknowledge the impact that's had. I wanted to thank the staff that have dealt so effectively with it, but just make people aware that this has an impact on our patients. This has an impact on our patients. Some people are waiting longer, and it has an impact in terms of the disruption when you have all these patients you have to phone up, you have to rebook, you have to go back through those processes. It's therefore particularly encouraging that in terms of us following the government's current mandate, which I've set out here in section 4, which first and foremost you'll see that the government expects us to cut waiting times for services, that we're making excellent progress for that. We won't hit a milestone of no people waiting over 78 weeks at the end of this month, because that's 2 days away, but the numbers that we will miss that by are very small, partly attributed to patient choice, partly attributed to the complexity of certain patients' conditions, and also partly attributed to that industrial action. But we are confident that as we work towards the government's target of bringing waiting times down again by the end of this year, that the rate at which we are treating people is above the run rate required for us to hit that target. So again, our hospital's making excellent progress in addressing that. You're going to hear later about the primary care recovery plan, so I'm not going to talk about that now. Again, trailed within here and trailed significantly by the government, we are expecting in the week of the NHS's 75th birthday, substantial announcements about a long-term workforce plan for the NHS. The first time that the NHS in its 75 years will have had a workforce plan that spans a longer period than a spending review cycle. And again, to have a workforce plan that actually spans the period of time that it takes to train a future doctor, a future nurse, future other professionals, will be something that we significantly look forward to. And again, I expect after that, we'll be coming back and talking to the board about our ambitions to see an increase in training numbers in the Cheshire and Merseyside areas. I think it's just really important to note, but not probably to discuss in this forum today, that the Lucy Letby trial that's affecting the Countess of Chester Hospital comes to an end in the very near future. You know, the judge has indicated that the jury will be retiring to consider their verdict on 3rd of July. One of the things that we have not done is we have not significantly discussed this at any time as a board, because we cannot be in a position in any way, shape or form to undermine a proper judicial process. But actually, whatever the verdict, there will then be an awful lot to consider and an awful lot of issues around lessons to be learned. So NHS England have now established a working group to look at what happens immediately post the trial. And again, that will be dependent on the verdict. It will perhaps be dependent upon what the Secretary of State has to say immediately following that verdict. But our Director of Nursing, Chris Douglas, she is on that group and will keep us closely informed of what's happening in that regard. I just wanted to say a word about COVID. And I want to say a word in two regards about COVID. One, the COVID inquiry is underway. There'll obviously be a lot of publicity as certain politicians appear before the COVID inquiry, but this is an opportunity to learn lessons, but this is also an opportunity to show a huge deal of respect to those people who lost loved ones through this process, make sure that their stories are effectively told and that we learn lessons. It's also fair to say that we've seen the systematic stepping down of a range of services that existed through COVID, and we await notification from the advisory committee as to what we will do this autumn. But our expectation now is COVID booster vaccinations will be scaled back and probably only available to those people who get the seasonal flu vaccination as a matter of course during the NHS. So again, notification in here that a range of routine services have been scaled back, including some of the routine record keeping that was made around immunosuppressed patients, but again, really clear advice and guidance put in place through 111 and also managed by Merseyside on behalf of the whole system in terms of those immunocompromised patients if they were to again contract a bout of COVID and how they would access fast-track treatment. I wanted to commend our directors of public health across Cheshire and Merseyside who work together as part of the CHAMPS Collaborative. They have made a very, very clear statement on the impacts of vaping and the desire to make sure that young people in our societies are not felt under various degrees of pressure from the retail sector to engage in something which does have consequences and is addictive. So I want to commend our Directors of Public Health and to advise our Directors of Public Health that they have the full support of our board to continue to push for further action in this area. And finally, this is an incredibly circuitous point. In section 14.2, there is something that we haven't documented quite carefully enough, Chairman. And that was, in our executive team, we did have an update and a discussion about what's called here loosely the Sustainable Hospital Services Programme, but I neglected to say within the paper that that was about East Cheshire. There's still much work to do about East Cheshire, and that was probably little more than just a kind of quarterly update that my exec group had received. But one of the things that I think it's really important to say and note today is, as a consequence of COVID, maternity services at Macclesfield Hospital were closed. Even when we had got beyond COVID, changes in working practices around the availability of anaesthetist cover, but also the requirements post-COVID to still have isolation facilities at the hospital meant that it wasn't easy to restore maternity services. Maternity services have been now restored, and that was partly dependent on a range of recruitment. It was also partly dependent upon some high levels of scrutiny to make sure that those services would be safe. And I'm pleased to report that not only did maternity services reopen at Macclesfield on Monday, but the first baby was born there on Monday as well. And I think probably by now, probably another 10 or 12 babies have been born within that service. So something I know our colleagues in East Cheshire are particularly pleased and proud about, and something that the board should note today. And there is significant comms already released about baby Oakley. Thank you very much.
Thank you, Graham. Can I take any questions or comments? Neil?
Yes, thank you, Chair. I've got a question on paragraph 2.3, but it might be picked up later by Anthony, so I'm happy for it to be left late, but the questions would be something like, so you can prepare, I'm sure you've got the answers anyway. We're at 19.4, the target is 10%. Have we got a trajectory over time of how we're going to get there? Second question would be, we had an intervention team in, how helpful was that, and what have we learned? And the third question would be, the virtual ward operating at 55%, is that good value for money? Should we be doing something differently? So them are the questions, perhaps pick up later in your report.
Thanks, Neil. We've got Steve and then Paul.
Thanks, Graham. Just in terms of section 3 on the Hewitt report, thank you for bringing that to our attention, but it is profoundly disappointing that the government's response around the actual percentage of funding going into prevention is not going to be accepted. I think I've made the point here before, since public health joined local government in 2013, in real terms, it's fallen by probably about nearly 20%. And the fact that the government can't commit a percentage to prevention is very profoundly disappointing.
Graham, do you want to make it?
I absolutely acknowledge that since the public health grant moved to local government in, 2012, it has been cut every single year, and there are consequences of that. There becomes then a very interesting point, isn't there, about whose responsibility it is to fund some of these services. And of course, the NHS, in much of what it does every day, is funding secondary prevention. Much of the work that our GPs do in terms of detecting diabetes, treating diabetes, would count as prevention work. Now, I think what Hewitt was trying to describe is that each ICB should, through its financial planning and strategy, set out really clearly how much of our budget is being spent on prevention and commit to increasing that over time. Now, even though the government didn't accept that rate of increase that Hewitt described, I still think that as we continue to model our financial strategy, and particularly through the work of our health and care partnership, we should look at that and we should test ourselves about our ability to make sure that our resources are increasing in that area, even though the government won't have set us a target.
Thanks, Graham. Paul?
Thank you, Chair. Graham, you didn't mention point 9 in your report, the Cheshire Merseyside Carers Charter, which I've got to say I very much welcome, as long as this group complements and supports the work that's done at local place level and doesn't duplicate anything. The figure that you refer to in 9.3, I've raised this at a previous ICB about recognition of carers by GPs. I think that is a huge underestimation of the number of actual carers that there are across Cheshire and Merseyside, and I think the target needs to be more ambitious than that, actually, and I'd really like to see this being given a huge boost. I think that there would be a payoff in providing support to carers, which would then in turn lead to less pressure on the NHS if we can do that. And this is a real prevention issue. Also, Chair, I'm just wondering when there's going to be mention of the fact there's a delegation here this morning from patients group from Liverpool, along with Paula Barker, Member of Parliament, here to challenge the decision that had been made around the Parkview Health Centre in Tewbrook in Liverpool. I'm just wondering when the issue is going to be raised on the agenda.
Okay. Can I just make a comment on carers, and then Graham will talk about Parkview. Firstly, Paul, the sentiment that you talked about, absolutely support that 150%. Carers are a huge army of people who support the great work of the NHS. They're the unpaid workforce of the NHS. And I do share your ambition about let's make sure we're hugely innovative, forward-thinking and ambitious in our expectations and what we do around supporting carers. Can I suggest we return to carer strategy at board? I'm looking at the exec. In due, give me a timescale when we hear a lot more about the carer strategy. Claire?
We can bring something back in September.
September, great.
I think also we probably want to take it as part of the HCP as well, particularly because of that joint working. I think it probably sits as well there than it does in the ICB. So we'll bring it back to both, Paul.
Thanks. Do you want to say?
In terms of Parkview, I think what the Chair indicated at the start of the meeting is immediately following this meeting, members of the board have agreed to meet the public to discuss the concerns that they want and the questions they want to ask us. Okay.
Thank you, Chairman. It was just a comment really, and a point of maybe some assurance in 2.2 around operational pressures, where we refer to corridor care being a big concern within the system. And I just wanted to share with the board a number of recent visits that I've made to our acute organisations with an ED facility, where they would not want to accept corridor care as what is described as a normalise it. But as part of the visits, I've observed and looked at it from a quality and a safety point of view to ensure that should corridor care be enacted, that is done with quality and safety. So I just wanted to provide that assurance. Thank you.
Thanks, Chris. Really important. So I'm going to take the liberty of just doing something that's not on the agenda. Now, ask Chris, Joe, Hilary, let's all stand up. Chris, if you could just lead the conversation.
If I stand up, I might not reach the mic, so apologies. Okay, so I hope everybody can hear me. So the Chief Nursing Officer for England, who's Ruth May, makes awards for nurses and midwives who have achieved and excelled within their practice or their leadership. And we have a couple of awards to make this morning. It has been a little like Secret Service this morning. So, Joe, we've got this covered, haven't we? So we have 2 awards to make today. There are silver awards and we have a gold award. So just a little bit about the citation that's been given for these 2 member of staff. And then I'm going to hand over to Jo, and then Hilary, in her previous role as Deputy Chief Nursing Officer England, will make the presentation. So the first individual has been awarded a silver award from our Chief Nursing Officer, and the citation said that this individual was dedicated, professional, compassionate, conscientious, and was an asset to their own team and also a credit to the Trust. They ensured that everybody's voice was heard and that individuals can share their opinions so that they feel respected and involved. And this person continues to learn and improve their own knowledge and skills. And throughout the pandemic, they put themselves forward for additional duties to ensure safety of the service and to offer, most importantly as well, to colleagues. They are extremely passionate about equality and fairness and is a true advocate for our BAME colleagues and patients alike, and regularly challenges discrimination. Our Gold Award citation says that this person is described as a dynamic, inspirational leader with extensive experience of delivering on a broad range of community services from children to adults. And you'll hear them say, nursing is in my blood, and I have heard that myself. They have a passion for healthcare and improving patient experience. They've had experience both regional and national levels, but her leadership has never been more compelling during the recent pandemic, when they demonstrated calmness and authority. But they did that with a highly professional approach. This person's visible at every level, is easy to communicate and offers a balanced and appropriate level of challenge. They're described as a champion of patient and service users. She's an exceptional nurse and team player and recognised for all her outstanding efforts. So I'm going to hand over to Jo to say who they are. Thanks, Jo.
Thank you very much, Chris. So it gives me real pleasure, as in my role today as Chief Executive of Merseyside, to introduce the 2 people who are both team members at Merseyside. The first is Solomon Guatizo. Solomon, do you want to stand up just so we can see you? Solomon thinks he's here to do a presentation. So I'm going to have to visit the priest and go to confession after all the fibs I've told the people. But Solomon, or Sol as he's known to his friends, has been a nurse for 19 years. Chris spoke beautifully about his contribution. I just want to reflect a little bit about what Solomon does professionally. He works in our secure forensic services, so working with people who have got severe enduring mental illness, people who are actually some of the most vulnerable people in society. And I think it's really great to see you awarded this just ahead of the 75th birthday. The NHS Constitution says the NHS belongs to all of the people. I think sometimes we forget people who are really seriously mental ill. And this is somebody who spends his time working with people really on the edge of vulnerability, who sometimes under the Mental Health Act, they lose their freedom and they're contained in institutions. And Solomon's new piece of work is now to help those people back out into community to live, full and fruitful lives. And I think that's a brilliant thing to be doing for people. And I know that your family back in Zimbabwe will, I'm sure, be receiving quite a lot of photographs today, is my guess. So Solomon, if you'd like to come forward and receive your award. So well done, Solomon. Enjoy the rest of the day with that little surprise. You can come back and give a presentation another time. The second awardee is somebody who really doesn't need introduction, but it's Trish Bennett, who again, I told Trish she needed to deputise for me today, and bless her, she printed off all the board papers and read them last night. So she's probably the most knowledgeable person in the room at the minute. Trish has worked at every level of the NHS, from very local level, regional and national level. I've still to meet anybody who doesn't know Trish Bennett. And I'll just say very quickly, I once walked into a room with Trish to welcome a group of Japanese visitors. And one of them stood up and said, "Hi, Trish." And I kid you not, I still don't understand that, but everybody knows her. She's been a tremendous drive for people with mental health, learning disability, and those availing of community services. Passionate about quality and outcome. Somebody, when we talk about seeing the whole person, that's Trish. She sees their physical, their mental health, their social needs, their housing needs. She's constantly a huge driving force for that. She's also my deputy at Merseyside, so does a load of other stuff, and still, I think, retains all the admiration, not just of all of our staff in Merseyside, but definitely all of our nurses in Merseyside. And the one thing I'd say, which she will never say, is I know she gets huge numbers of phone calls from people saying, "Trish, you wouldn't just," or "Would you have a word with me? I need a piece of advice." And all of those things get stuffed into her incredibly long, busy days. But the one thing I'm absolutely certain is she never says no. She really is the nurse's nurse. So Trish, come and get your award.
Sorry about this.
Oh, wasn't that good? So, let's go to Tony, the report of the Place Director.
Thank you, Chair. Really quite difficult to follow those accolades, but I'll have a good go. I don't know if my presentation could come up. Great, thank you. Well, good morning, everybody. As I mentioned before, my name's Anthony Leo. I'm the Place Director here in Halton. On behalf of our Place Partnership, many of whom are sitting in this room somewhere, just offer you a really warm welcome to our place here in Halton in Cheshire. So today, really, I just want to give you a bit of an overview of who and what we are. I want to describe some of the challenges that we face, but then set out what our ambition is for our residents and our patients and our citizens, and then describe some of the work that we're trying to undertake to push forward and to meet those challenges as we go along. And then towards the end, I'll just say a bit about our partnership, and obviously I might allude to some of those things as we go. So, Halton Place, so where are we? So we sit in the county of Cheshire. We really consist of two main towns of Widnes and Runcorn, and we are geographically separated by the River Mersey, which separates those two towns, but is connected by two bridges. And we serve approximately a population of about 130,000 people. And we have two PCNs located on each side of the river, and those populations are roughly equal in themselves at about 65,000, so a good size, really, for what we need to achieve. We have 18 electoral wards in quite a small space, and two parliamentary constituencies, and we also have quite a big chemical industry heritage, which originated mainly on the Widnes side of the river. So just some quick facts about Halton's history for those of you that may not be so familiar with the place. And a member of the team drew some of this up, but you will actually recognise a number of the features in here. So Runcorn itself was founded in 915 AD. We have Halton Castle up the road, and there is also Norton Priory, which dates from 1134. Really proud to have on our patch as well the Daresbury Labs, which opened in 1962, and those were opened by the Prime Minister of that time, Harold Wilson. And of course, you know, those activities at that site remain world leading, with a number of researchers winning Nobel Prizes. And it's the home in terms of development of some of the most advanced technologies in computing, data science, and AI. So a really good resource just on our patch sitting here in Halton. Some of you may remember back to 1972 when we opened Runcorn Shopping City, which is located just down the road. At that time, it was the largest indoor shopping centre in Europe. And then just for today's purposes, within there, we have something called Halton Health Hub, which is operated by our trust colleagues at Warrington and Halton Hospitals NHS Trust, providing a range of services in our community in a really accessible place. And that opened, started operating towards the end of last year and was formally opened earlier this year. And then, of course, I'm sure some of you this morning will have used the new Gateway Bridge, which was opened in 2018 by the Queen. Now, that took 3 years to complete, but it has supported a whole load of jobs, secured inward investment to the area, and delivered important regeneration benefits for the people of Halton. So, I've mentioned our Halton Place partners. We have a really wide and diverse group of providers and partners within there. On the left-hand side of the page, you can see the range of health providers, but also our care providers, our local authority colleagues who have joined us today. But I probably want to make special mention of our third sector and voluntary sector colleagues who we work really close with. We've got really strong relationships with them, and they are really helping us to drive some of the address some of the challenges that we have within Halton through their connections, how we connect with them, and then how they connect out really into the heart of our communities. So really strong partnership. And then on the right-hand side, it just gives you a flavour of the different organisations that really cut into Halton's space, and we all meet fairly regularly. Last we all met yesterday at our partnership board meeting. So that forms the basis of our place partnership. Now, I'm sure you've seen lots of these slides in previous presentations or about the place, but this quite simple pictorial really is, if Halton was a village of just 100 people, and clearly there are some stats in there, but obviously there's some quite stark facts in there. If you look at some of the numbers, a couple of the ones that stuck out for me were around, 32 people die from cancer out of those 100 people. 78 are classed as overweight or obese. 19 people have more than one long-term condition. 17 adults live with depression. I think that's just a really good snapshot of out of all of the data that we have that we can describe quite easily to our citizens and residents and colleagues here today. If we just take that a bit further, and again, I'm sure you'll have seen this is quite often described as the snake of health, and it really charts the life course from start well through to live well through to aging well, and it covers a number of different conditions, indicators. I suppose what I would say is in terms of our population, I mentioned that we are about 130,000. By 2041, that population will shift quite dramatically. That's what's estimated, and a particular shift towards the 65 plus group. So that will be quite significant for us in terms of how we shape services to manage that over the next 10, 15, 20 years. In terms of our deprivation, I think about 48.7% of our population live in the top 20 most deprived deprivation in terms of the index of multiple deprivation, and 19.6% of our children live in poverty. So those numbers are really quite stark. I know you won't be able to read actually some of the detail on there, but you'll probably be able to pick out some of the red circles. You'll notice there are quite a lot of red circles in there that relate to things like long-term conditions, disability, cancer deaths under 75, and self-harm admissions. I've just picked those few out, but obviously there are others. They're red for a reason, because we are statistically worse than the Northwest average. So it paints quite a difficult picture for us here in Halton and some of the real challenges that we have within our communities. Just on the next page, now I know you won't be able to read this, but actually it's the colours that are important in this. This is what we term our tartan rug, and I'm sure you will all have seen those in other places as well. But here what we're trying to demonstrate are the health inequalities across Halton. So across the top row you will see our 18 wards, left to right, and then on the left-hand side are the range of different health conditions, whether that's chronic kidney disease, COPD, cancer, long-term conditions, etc. And one of the things that I would say is the darker the blue on that table, then the higher the rate is, so the higher rate per thousand of particular conditions, so i.e. the worse it is. And actually the story paints quite a clear picture. So if you contrast a couple of wards, so there is a ward about, I think, fourth in, which is, I think it is Birchfield. That's a lot lighter than, say, for example, Halton Lee. So it really paints the picture of disparity and inequity across our wards, and that happens to varying degrees, but we can easily spot where our challenges are from that table. Just to illustrate that point a bit further, just to say a couple of words around life expectancy, both compared to England and to our Halton wards. So on the left-hand side, you can see that Halton is coloured in the blue. It's the fourth from the right, and then the northwest is in the grey in the middle, and then the other two lines represent the national positions. So here, compared to England, life expectancy for Halton men is 2 years lower than the national figure, and for women it's 1.7. And you can just see there where we sit in terms of our other places. So we're more to the right-hand side, so our life expectancy at birth is lower than, say, for example, the Cheshires on the left-hand side. We're more or less, I think, on the northwest averages in terms of where we are, but we are certainly less than England. And again, that just highlights some of our challenges. To illustrate the inequity across the different electoral wards, and I think we need to remember geographically we're not that big, but actually, on the right-hand side, that's where life expectancy is greater. So that's a place like Daresbury, Sandymore and Moor. And then on the left-hand side, we can see places like Bankfield, Halton Lee, etc. So there is a real range of difference across that. And one of the things we're wanting to do is really drill into that further with our public health colleagues. But just to give you an illustration of the difference, so between the greatest and the smallest numbers, that's an 8.6 year difference for men and an 11.1 difference for women. I don't think I personally have come across anything that stark across our patch. I was really quite shocked when we had that discussion around some of these figures. So, what does our data tell us? What's driving in terms of health inequalities? In terms of health conditions, I don't think these come as any surprise. It's around cancers, respiratory disease, circulatory disease, digestive disease, including liver disease. And then a range of lifestyle factors, smoking, unhealthy diet, not enough physical activity, being overweight, obesity, drinking too much alcohol. And again, I don't think those are any surprise. And both of those really are driven by social conditions around poverty, educational attainment, employment status and type of job, and housing conditions. And those really do speak to the wider determinants of health, and that's why within our strategy, as you'll see later, we've got a real focus on those wider determinants and some of those things that we need to try and address really on with our really wide range of partners. I'll speak a bit more about that shortly. So with all of those challenges in mind, what is our ambition? So it's contained within that red text statement there, but largely to improve the health and well-being of the population by empowering and supporting local people from the start to the end of their lives. And that's taking account of preventing ill health, promoting self-care, promoting independence, but then making sure we've really got the services wrapped around those that need them so that they can access them in a really timely and easy way. We have a long history of working together in Halton, and actually I think we firmly believe that the health reforms that were created from July last year afford us a real and exciting opportunity to work together in a different way and to accelerate some of the things that we've been talking about for a long time. And certainly since I've been here, I've seen partners' commitment to do that and to challenge each other to go further and faster. Clearly that's not without its difficulties, because we all come to the table with different issues and different things, but nevertheless there is a real willingness to work together and take advantage of the opportunities that we've been given via the health reforms. So we see One Halton as the driver to help us to achieve that, described as the One Halton Way, and that means a big focus on recovery from COVID, further steps to address unequal access to care, reducing poor care experience, improving outcomes for Halton residents, and developing Halton's workforce. So, what's the golden thread? The golden thread for us starts with the Joint Health and Wellbeing Strategy. We agreed that back in November 22, and that sets out really 4 thematic priorities. We'll come on to a 5th in a second, but effectively, you know, it's around start well, live well, age well, but actually the wider determinants of health is a big feature in what we're wanting to do, and we've got a separate work stream around that. There are a range of measures on there. You won't be able to see them from where you're sitting. The text is too small. But basically, just to say, each red triangle highlights we're worse than the Northwest against a number of indicators. And as you can see, in each of those thematic priorities, we are worse than the Northwest. So we just need to address some of those issues. This next slide then just tries to put on a page what describe our ambition, our priorities, but then what our goals are for each of those strategic priorities, what we want to achieve at the end of the day. But in doing so, it's about framing how we support our vulnerable groups, how we use the Marmot principles, altogether fairer, to make sure that is part of a real fundamental part of our work, and how we address those health inequalities, address the core 20+5 issues. But at the same time, we can't forget about delivering on our day-to-day business as usual as well, in terms of our operational plans and our long-term plans. So that is really important for us. So just in terms of addressing those challenges, what do we want to do to address those challenges? Well, it's about creating and understanding the impact of poverty, health inequalities, as I've described, those wider determinants, and the focus on prevention to tackle those drivers of the life expectancy gap. We've agreed some early priorities, which I've described on this slide, and this is by no means all of the work that we're doing, but I just wanted to give you a bit of a snapshot. So in the Start Well space, we've got stuff around family hubs, developing 2 family hubs. We're already well on the way to doing that. In terms of the Live Well space, we're doing work around prevention, screening, healthy weight, cardiovascular disease, but also mental health and well-being. And some of those challenges was described to us by our colleagues from Merseyside, who are an active part of our partnership. In terms of ageing well, it's around end of life and social isolation, but there is a whole load of other work going on as well around care homes, how we support those, how we improve quality, etc. The other key theme that I wanted to mention for us is integrated neighbourhood delivery model. Really, that is a fundamental feature for us, and that's what is really underpinning what we're trying to achieve here in Halton. We don't have a direct contractual relationship with either of our acute trusts. Those are dealt with by other places. So we feel we have a real opportunity using and harnessing the power of our local services, but with our acute partners and our community colleagues in the same space to really drive an integrated neighbourhood delivery model. And one of the key features of that is around same-day primary care and access to appointments, which we've already kicked off. So some of the examples of things that we're working on: the integrated neighbourhood delivery model is the basis of what we're doing, but we're looking at things like urgent and emergency care, including admission avoidance and discharges, same-day primary care development, mental health and learning disabilities, end of life. But one other thing I just want to say is about our real integrated working with our partners, and particularly when we think about things about supporting vulnerable people and fuel poverty and just poverty in general. We've done some good work with our local authority colleagues on this, and we've got some good resources there for our populations as well. And then all of this is underpinned by a financial maturity framework, a digital strategy, and an emerging estate strategy as well.
Tony, I'm going to ask you to just pause on there, because I think the remaining slides are about governance.
Yes.
And members are very... I encourage you to ask questions about governance outside of the meeting. I'm pausing it simply because we're running out of time. You've seen fantastic ambition from Halton, and we can... and I really like that focus on the neighbourhoods. That's fantastic stuff, Tony. Can I seek any comments, questions from the board on Tony's presentation? It's here really to enable us to get into Halton. It's really informative. People comfortable. Erica?
It was a really powerful presentation. What I'm interested in is the integrated neighbourhood delivery model. And I know under that you actually put the primary care. I just wondered if you could bring that to life. You know, what actually are we looking to achieve?
Yeah, so here we're really looking at about how we work together. So we've agreed a set of principles as a partnership board about what that means. You know, that could be single points of access. It's how teams work together, how patients have a more seamless journey than they do now. They don't need to tell their story multiple times. They're clear about where they can access services, when and how. What we're really clear about, this is not about colliding teams and staff together into a single organisation, but actually this is about a way of working. But also, because it is around the neighbourhood delivery, it's about understanding some of those health inequalities within wards. And, you know, a key foundation for this are our primary community services and what we're offering in the community, and then how our acute partners and community colleagues coalesce around that.
Thanks, Erica. Thanks, Tony. So if there are no further questions for Tony, I'm going to ask for your indulgence to move the agenda around. So if I could ask Joe.
Thank you very much.
Oh, apologies, yeah, Joe, I've missed the patient
Patient
story.
Okay.
Yeah, apologies. Patient story, who's going to deliver that?
Sorry. So, yeah, this is our Halton patient story, really. So this hopefully will bring to life some of the things that I've described around our integrated way of working. So this is about the Halton Integrated Care and Frailty Service, which was established in 2022 and is a partnership between our local authority colleagues, Bridgewater, but our acute colleagues really are active in that space as well as our other community services and our general practice colleagues. So you can play the presentation.
The Halton Intermediate Care and Frailty Service brings together health and care professionals from organisations across Halton to support frail people and their family carers based on their needs. The aim of the service is to keep people in their own home wherever possible. When someone is at risk of needing to be admitted to hospital, a rapid response approach is used, which means the person is usually seen within 2 hours or the same day, and a care plan is put in place. The team also manage hospital discharges into intermediate care bed bases, bringing in support from health and care services across Halton when needed. The team provides a person-centred approach which focuses on improving the quality of life of Halton's frail residents in their own home. Ruth from Murdershore, alongside Julie, her nurse, told us about her experience.
Matthew, will it be on the website? I know all board members will have a look at it, and members of the public will have a look at it, and my sincere apologies for the technology letting us down. I am going to move to Joe, because I know, Joe, you do need to go. If we could go to your paper.
Thanks very much, Chair. This refers to agenda item 11, which is an update on the Mental Health Community and Learning Disability Collaborative. I'll assume that the paper's been read by and large and just pick off a couple of points. This paper's been subject, or the development of this collaborative has been subject to an awful lot of consultation. Because by the very nature of the services we're talking about, they're often provided in collaboration with a whole multi-agency spread of partners. So social care, voluntary and community sector, primary care, acute organisations, etc. I think in our conversations it's clearly too early in the development of this sort of collaborative to have reached an agreement in terms of how the collaborative will function, where all of the agencies who could play a role will be part of the collaborative. That's not to say then that we don't see that as a longer term objective of this collaborative. But as it stands now, and with the help of Steve Broomhead down at the bottom end of the table, we've been clear that the current proposal for this collaborative is about 9 NHS provider organisations working together horizontally, fundamentally on NHS issues in the first instance. So the detail in the paper describes the production of standard models, standard approaches to managing waiting lists, which for these services actually have grown under and since COVID and are now very long, to ways to think about productivity around these services, because often the way they've been commissioned in the past has led to high levels of duplication all across Cheshire and Merseyside. To think about best practice sharing, a sort of very basic thing to do, but we know would enormously improve the offer for patients, and to think about new outcomes type based models as we go. So we have identified several key areas. Access, so can we be clear about what the standards to access are, how long patients are waiting, that we're counting those issues in a consistent way, and that we have systematic approaches to sharing best practice. What's really, really clear is some of us as a group are doing really well on these things, others less well. So it's the age-old issue, isn't it, of coming together, sharing that best practice, and then rolling it out. To have a focus on community urgent care, which we know in our environment is really, really important to us. And actually for that to be productive, we need to think about being able to manage those sorts of services much more in real time. So there's a feature there. Thinking also too, particularly about services for children and young people. Some of the issues will be subsets, waiting times and those sorts of things, but it's very clear across the piece that for NHS young people and children's services, there's a real significant opportunity for us to move the physical and mental health and learning disability components of children and young people services together. To think then specifically about mental health and many of the pressures we often hear about, but specifically people in crisis, and people in crisis who sometimes in Cheshire and Merseyside, because of the incredible pressure on our beds, are moved to other parts of the country. And that's a significant issue for some parts of Cheshire and Merseyside. And we absolutely feel there's an opportunity there to do quite a lot of stuff differently. To think about population health management for NHS services, so that we begin to think about, as providers of NHS services, how we can define the population of patients who come into our organisations differently. So just thinking about Tony's presentation, we know that people with COPD who come to see us, 40% of those people have moderate to severe depression. So we can do a lot more to manage those patients in a single setting and a single consultation, so that we don't sort of cure the physical issue, but people still live miserable lives, if I can sort of phrase it that way. And then there are issues of workforce that are common to us all. And lastly, we believe there are some significant efficiencies of scale working that we can deliver. So not very dissimilar to the CMAS type of approach, but different types of services where I think we do need a slightly different separate approach. And that will form the basis of a delivery program. So it's important to say, I think, that this approach will come forward with more detail, I'd suggest in September, when we've taken the proposition through our boards, which is due to happen, and when we are able to come back with a fleshed out governance arrangement. It's alluded to here, but not yet fully developed, and with a more detailed and timed delivery plan. But at this stage, this is sort of ready to go proposition.
Thanks, Joe. Can I see comments and questions? Erica?
Just a quick comment from me, Joe. Just to say, really great to see such clear priorities. My only thought was around, this could probably be in the governance paper, just around the workforce, because there's various different groups looking at system workforce, and it's to make sure that we're not crossing over other ones, and how that all reports through would be good.
Yeah, I think as we've talked about it, Erica, we realise that these are sort of subsets. We've got to be really careful that we're not doing somebody else's work or duplicating. But I think there are some things that the collaborative can do, but there are definitely things that need to be owned at Cheshire and Mersey level. So got that one.
Thank you. Steve?
Well, happy to support the principles of this paper. I mean, it's going to start a sort of development journey. I think, as Joe said, I mean, you can't deliver some of this activity in an integrated way without the involvement and engagement of local authorities and the voluntary sector. We've had good discussions about how we wish to engage. We're doing a lot of this at place already, yeah, but there is clear benefits in the NHS organisations working collaboratively, as Joe has said at some point. Hope there'll be an interface around the work of councils. One thing coming our way is right place, right care, right person, right care, right person. The police service in Cheshire are about to withdraw in September for intervening with people with mental health difficulties who are facing significant issues around events. And we probably need to engage on that as a system for Cheshire and probably for Merseyside. It's going to be a national edict. And I think through the work of this collaborative, we can probably work collaboratively to make sure we don't get shunting in terms of behaviours and shunting in terms of costs if the police are withdrawing from their support of those interventions.
Thanks, Stephen. Thanks for highlighting that risk. I've got, sorry, Tony, then Paul.
Thanks, Joe. I think the section that caught my eye was population health management. I wasn't expecting to see that in there, but it is very, very welcome that you're taking that approach. But the other thing that struck me reading through it is the number of references to partnership working all the way through, and that's the whole out of this. It's not just the collaborative providers working together, it's that collaborative working in a bigger partnership, so hugely impressed.
Thanks, Tony. Paul?
Thank you, Chair. First of all, I very much support Steve's and Tony's comments. I think the idea of sharing good practice across the whole of the system and raising standards has got to be welcomed, and also getting common data sets and working to the same sorts of principles and raising the profile of mental health, particularly I do welcome. Just as a paper, though, I'm wondering how this fits vis-a-vis a paper that appeared on the agenda a number of months ago about the role of this collaborative. That proposal at the time, there was to be further work. I'm not clear as to is this development from that, or have those previous that previous a big idea in a sense, has that been shelved?
Shall I answer that? Well, I think for the time being, Paul, the big idea is shelved. I think it might have been too far for some folks, but I mean, it is worth recognising that, in fact, the work that we've awarded Solomon for is exactly that sort of model where providers take the budget and try and do different things. But I fully accept that, you know, we've had a really strong, productive conversation that says we need to go at the pace at which folks want to go, and that we take partners with us rather than leave partners behind and slightly irritated, if I can sort of put it that way. I'm not suggesting you're irritated, Paul, but so I think it's fair to say this replaces that paper, if I can put it that way. And I think as we take the references to partnership as we go forward, I think we're very clear in the conversations we've had with Steve and others that actually those partnerships are through co-production, you know, rather than being produced and sort of rubber stamped by and have to be accepted by folks.
Thank you. Thanks, Joe. So, sorry, Graham, go ahead.
I wanted to respond to something that Steve Broomhead said, and this is about the Right Person, Right Care initiative. And for people who don't know this, broadly, police services nationally have said, you know, it's not their job to pick up people who have a mental health problem. It's not their job to be the carers for people with a mental health problem. Now, the NHS has had some targeted investment to change the services that we provide in these spaces. and again, perhaps we could bring something back here to a board at a later time. So certainly having mental health nurses out in a car, you know, being able to be the first response to people in crisis in their homes. We also have a situation where when these people do then present in our acute hospitals, because that's been deemed at some point in time to be a place of safety, the care arrangements that we put in place for these individuals gives me and the management team great causes for concern. You know, the fact that people are staying in you know, kind of isolated rooms for a number of days because there's not an appropriate care setting for them. They're having a number of, shall we say, security type guards, you know, there to protect them and protect staff and people around them. And so we've been working really closely with both police and crime commissioners, and I'll have to check out the position with Cheshire, but certainly I know this is on the agenda of the Merseyside Police and Crime Commissioners meeting in July, and I think you'll find that myself, one of our place directors, and also Trish Bennett, who you've met here today, will be attending that meeting to give further assurance to police colleagues about the ramping up of healthcare services to make sure that we're really clear about here's what the police do, here's what the NHS does.
Thanks, Graham. Steve?
Well, welcome that. I mean, in Cheshire, they've been designated by the Home Office as an early adopter, and they'll start to roll out this in September. So if we could have some consideration from a system-wide approach to this, because quite frankly, if the police don't turn up, they're expecting council social workers to arrive. I'm in a distressed state along with all my other council colleagues. We just don't have the staff to do so, nor do we have the resources. So I'd welcome a proper discussion about it.
Thanks, Steve. So, Chair, we're seeking to note the approach and the progress made by the collaborative and to endorse the commitments made in the work plan. I did note that you have promised us a delivery plan in September, I think you said. September, October, that time. It's going to be really important, isn't it? Because I'm sure the board will want to see what the results are of the ambitions that are articulated in this paper. So thanks, Joe. I know you need to go as a matter of urgency. If we can return to the agenda, it's agenda item 10, I think. Joint forward plan. Claire.
Thank you. I'm going to say a few words before handing over to Neil, who's done absolutely the lion's share of this work on behalf of all of us, so he needs to get the credit. So, just to say, it's statutory requirement on all ICBs and partner NHS providers to develop a 5-year joint forward plan, and we have to publish it by the end of June. So hopefully you support it today. We can publish it in line with the national timescale. The joint forward plan is the shared delivery plan for our healthcare partnership strategy and our 9 health and wellbeing board strategies, along with the core NHS universal priorities and our statutory duties as an ICB. The joint forward plan outlines our commitment to 3 key things: improving the health and wellbeing of our population, improving the quality of services, and making efficient and sustainable use of NHS resources, all of which I'm sure you'd support. Alongside the 5-year joint forward plan attached today in the papers, we've also produced an annual delivery plan, which outlines the ICB's priorities and objectives for 2023-24, and these are taken from the joint forward plan. As Raj has said, we're coming to the end of our first year as an ICB, and as part of the wider Cheshire and Merseyside ICS, we'll use the learning that's undertaken over the past year and all the engagement we've done for these documents, I think, to improve and develop how we want to evolve in the future. So I'm now going to hand over to Neil to talk through the plans and their development in detail, but I just want to have on notice the sort of thanks for all the work to Neil Evans and to Stephen Woods for these documents. Thank you.
Thanks, Neil.
Thank you. So yes, I'm Neil Evans, Associate Director for Strategy and Collaboration at the ICB, and I've worked on coordinating initially the Health and Care Partnership interim strategy and now the Joint Forward Plan over recent months. I'm not going to go over all the background. I know you've most of you have heard it more than once, so I'm going to focus a bit on the content today and how we've developed the content. We've worked across the system. We've had a team who have helped develop the content from not just within the NHS. I recognise, as we'll come on to later, that there is a reflection that the proportion of content within the Joint Forward Plan is heavily weighted towards the NHS, and that's one of the consistent themes of feedback we can take as part of the learning that Claire references for future iterations. So we developed the Joint Forward Plan alongside the NHS operational plans. The document in your pack does have some final revisions happening as we speak. They're generally around accessibility, formatting, and we're creating links to supplementary content that sits behind that. Since I spoke to the board back in March, we've made a number of changes to try and refine the approach and content within the plan, working with partners, including visits to all of the health and wellbeing boards to get feedback on the document. And we also ran during March and April a public engagement survey around the HCP strategy and its priorities, which helped inform the content we've included within the document. We separately had a peer review session, which was really helpful with our two neighbouring ICSs in terms of GM and Greater Manchester and Lancashire and South Cumbria, alongside NHS England, to learn from each other and our approaches, recognising we'd all taken slightly different approaches, but it was helpful in giving each other feedback and refining content as a result to try and make sure that the key messages came through in the document. So the headlines in terms of some of the themes were, the obvious comment that we received was, at the time, I think the document was around 150 pages. It's now over 180 pages in terms of total content, that was simply too much and it was difficult for a member of the public to engage with. So the document in the pack, you'll notice, is much shorter and is effectively a summary version. We haven't lost the detail behind and some of the content that Joe has just been talking about. We have that detail. You will access it through a link from this summary document and be able to get at the areas you are most interested in, but hopefully this shorter summary version makes it easier for the reader to access. The other things you'll note are included is a smaller number of priority areas that we have included, and they were focused on things that colleagues felt we could make rapid progress and most closely aligned with some of the HCP priorities within that interim strategy. And we've also identified a number of areas where we know further work is needed, what we might call enabling strategies or subplans, which we will work hard to complete this year, meaning when we develop our next iteration of the Joint Forward Plan, which we have to do by the end of March 2024, we will be able to describe in a more holistic way how everything fits together. And then the final point, which Claire touched on, was we've developed a very detailed delivery plan that sits behind this document. The version in the appendix here is a summary of that plan, and we're currently working with colleagues from Anthony's team in terms of developing the reporting that sits behind that to give the board regular updates on progress in delivering this joint forward plan. The final thing I was just going to reference before opening up to any questions is we recognise that, and this term has been used a few times, the Joint Forward Plan is a nationally titled document, and one of the things a number of health and wellbeing boards have pointed out is the joint bit feels a little bit odd when 90% of the guidance refers to mandated NHS content. And one of the discussions which we've subsequently had at the Health and Care Partnership is how we can make our next iteration feel more like a system-based health and care plan rather than a partial health and care plan and a heavily weighted NHS plan. And you'll note a recommendation in the paper is that we look to create that kind of delivery plan for the Health and Care Partnership Strategy as our joint forward plan, and then sat alongside that as a appendix we would have some of that targeted NHS content, which is very much in the areas where the NHS is primarily delivering schemes such as things like the elective recovery programme, which we know is a key priority for us, but sits firmly in the NHS space. So the content's also there, but the way we present it would be in a more system-based way. So if it's okay, I'll stop there and happily take any questions.
Thanks, Neil. If I could just say a few words, which is this: the ambition that lies here is that this plan will evolve over time to be something that we all want. What do we all want? We want to be able to explain in understandable terms what the ambitions of the ICS, the Integrated Care System, the Health and Care Partnership, and the role that the ICB will play in delivering on those ambitions of the Integrated Care System. Explain it in terms that are sensible and understandable by members of the public, and members of the staff of local authorities, voluntary sector, faith sector, as well as the NHS. That's the ambition. And we're on a journey towards that. Neil and Claire and the team have done an extraordinarily good job of taking the mechanics, I'm going to call it that, of the NHS that forces a certain way of working and trying to move it gently, appropriately. Gently is not the right word, is it? Move it into a place where we're trying to achieve our ambitions of being able to have a set of priorities and ways of doing things that maximises the opportunities that we have in the ICS. We've just heard that this plan will come back to us in March of 24. But it's a really important document. It's informed the activities, the priorities, targets that we're going to work towards in this financial year. So, that said, I want to seek questions, comments. Ian.
Thank you, Neil. It was just more of a comment, really. Excuse me. It's really good to see that all the population health and health inequalities, the NHS core 20+5, and all the altogether fairer features strongly in it. So just it's great to see that in there, really. So and that reflects all the work going on across the 9 different places. So thank you.
Thanks, Ian. Adam.
That's on or not? Oh, there we go. Yeah, just to commend the plan. I think the beacon indicators of Marmot, I'm really pleased to see those in. However, a lot of the milestone trackers and the progress that's in the plan doesn't necessarily track them, and they're such a long-term effect that actually I do wonder how, as a health and care partnership rather than the ICB, we actually track our progress towards it. And I think that's the one thing that's missing from it at the moment, is how are we going to keep an eye on that? How are we going to measure whether we're making a difference or whether we're not?
Yeah, well, Claire and then Hilary.
I might answer that one if that's okay.
Yeah.
We actually discussed this yesterday, Adam, in terms of the healthcare partnership agenda for July and a sort of a forward plan. And obviously with Ian's appointment and sort of starting as our new Director of Population Health, we'll be bringing to each of the healthcare partnership meetings a sort of a performance framework around Marmot and the indicators, and obviously bring that back here on a sort of intermittent basis, but I think it sits within the healthcare partnership primarily. And I think, as Raj has said, probably this year we've responded probably too closely to the asks of the NHS, and I think going forward what we'll be looking at is probably having a single system strategy and then an ICB delivery plan, which will sort of pick out the priorities for the ICB. But I think it's tremendous work, and I think the engagement, particularly with the health and wellbeing boards and obviously our provider organisations who've taken these documents through their respective boards, it's the start. You know, we're a year in, but I think it's fantastic progress and something we can all sort of hold our hats to and sort of all our work for the future. So thank you.
Thank you, Claire. Hilary?
I think it's a great document. It's a real palatable read and quite intuitive as you're moving through. I think I've got 3 comments. I think, first of all, the safeguarding section, I think I think this is much stronger. I think the biggest shift in safeguarding in the last 2 years is that we share accountability with local authority and the police. And as we move forward, it'd be interesting to see or demonstrate how we exercise that accountability and assurance at place. But maybe that's not for the plan, that's just something that has occurred to me. I think secondly, the core 20, just let me get to it, core 20 plus 5 section. I was surprised not to see maternity in there, given the huge disparities, particularly if you're a black woman, where you're 10 times more likely to die during childbirth. And I know that's mentioned later on, sort of generically, in the Ockenden piece. And then finally, in this staff section, and I just want to bring the Marmot principles into this, because I think we have a duty to really promote anti-racist practice and anti-discrimination practice, bearing in mind that 1 in 3 of our posts that we're filling now nationally are from our very talented, internationally trained individuals. So my 3 comments, but a brilliant document and fantastic piece of work. Thank you.
Thanks, Hilary. Go on, Steve, and then Tony.
Well, welcome all the comments. It is indeed a really good piece of work, and particularly as it builds on the healthcare strategy, which was derived from place and uses the 9 health and wellbeing strategies. And it's got to be driven by place all the time. But obviously there are some national issues which NHS wish to draw to our attention. We have to work on, but mustn't lose the focus on place and the wellbeing strategies that we all have in our footprint.
Thanks, Stephen. It's then useful for Tony to come in at this time.
Thanks, Chair. I actually was going to follow a good point to follow on from, really, just to say from our perspective, you know, it's really helpful, this, Neil. I know we've had many conversations about this and how we manage it through, but broadly this aligns with our local health and wellbeing strategy. I think it is a valid point that has been made about actually how do we just get it beyond the immediate health must-dos next year, and that's been part of the reflection that we've had back. So that is really valid, and I think we in place would really welcome that, because we've got you know, lots of good ideas about the sorts of things we need to achieve. But thank you, really good document.
Thanks, Tony. Got Rowan and then Chris.
Thanks ever so much. I know it's been a bit of an NHS-centric document, but a lot of that is the background that we're all coming from, and we're learning the way we fit better with our local authority and that partnership bit. But that said, I'm almost to echo the population health side. We are explicit in this document that we must move from purely reactive healthcare to proactive healthcare. That is where we will start to make a real difference to the people and the populations that we serve. I'm also delighted to see that we are probably one of the leading systems when it comes to our statutory obligations around research and innovation. We've already heard about the work that goes on at Daresbury up there. And as a system, that is already starting to deliver. I was pleased to see that this week, one of our first applications into the NIHR has seen Cheshire and Mersey awarded £4 million to take research into the communities with a whole series of projects. And that's the first time we've applied for that as a system to deliver that. So the fact that we're already stepping in the right direction with much of this is really encouraging. And Neil, thank you again for all your hard work.
Thanks. I've got Chris, then Tony, then Paul.
Thank you. I think what's really quite stark when you look at the annual report is, or the annual plan, is that not one of those actions can be done in isolation from all of the others. And there's a real risk that because we've put where the governance sits, that we don't make the link. So I think as an executive team, we probably need to do a piece of work that says how do we collectively bring those together to provide the assurance rather than going through separate committees. And my second point was just to assure Hilary that the anti-racism framework will be coming back to this board next month.
Thanks, Chris. Tony?
Yeah, thanks. Just to counter this thought that this is a very strongly NHS-focused plan, which, because of the template, it looks like that. But my attention was drawn to the quality improvements and quality principles section, quite short and succinct. But within that contains the clue to our integrated progress. It gives one safe, effective, positive experience, responsive and personalised, caring, well-led, sustainably resourced and equitable being the principles that are shared across health and social care. So for me, that's one of the strongest elements of this. This is the way forward to focus on the things that matter to both areas of the health and care partnership. So in that sense, very strong documents. Thank you.
Thanks, Tony. And Paul?
Thanks, Chair. I echo that. I think there are quite a few of us around the table who really push integration to the fullest, and particularly around local authority involvement in this and the benefits of us working together. Just to say that this document was welcomed at the Sefton Health and Wellbeing Board. Hopefully we made some positive comments which have appeared here. To me, we're now getting to a point where it's making sense, the link between this ICB and, you know, I hate the word place, but our local areas and the work of the HCP as well, the Health and Care Partnership. And I think it gives us some ground to really move forward together and on all these issues, and also ties in the Altogether Fairer work and the Marmot stuff. So for me, it really does bring things together really well.
Thanks, Paul. Any further questions? No. Just one last reflection from me. We've just seen in Tony Leo's presentation the stark differences between the wards in Halton in terms of outcomes, population level, health outcomes. 11 years difference in terms of life expectancy for women in Halton. And we all know, don't we, what drives that is poverty. And I do hope that in 4 years' time, when we come to the end of the plan?
5 years.
5 years, 5 years. Not only have we made a difference to the NHS access targets, to some of the local authority ambitions and voluntary sector ambitions, we can clearly see that we've made a difference to the real lives of those people who live in such difficult circumstances. That's the ambition, that's the job of the ICS working together, HCB, ICB, and all our partners. Hugely important, Neil. I know you've done a phenomenal amount of work on this, including engaging within the constraints that we've got at this moment in time. And I know engagement going forward is really, really important to us, to getting this plan into the ambition that you've articulated, Claire, about being a system plan. So thank you very much. And the recommendation here is approve the publication of the 23-28 Joint Forward Plan on the 30th of June, albeit there needs to be some corrections, did you say? Some tweaks. So
it's more around formatting and passing accessibility checks. There's no material content changes
so I'm
proposed.
going to seek the Chief Exec, a delegation to the Chief Exec to sign off that final version of the document, if the board is supportive of that, and endorse the way that we're going to develop the Joint Forward Plan in months and years to come. People comfortable with that? Thank you. Good conversation. So let's go, Claire, to the annual report and accounts 2022-23.
Thank you. So there are 2 reports in the pack, and that's because the financial year for the NHS starts on the 1st of April each year, and we became a ICB on the 1st of July this year, as you know. So what that means is it's quite an unusual year from a financial point of view, and in terms of our statutory governance requirements and the reports that we have to produce statutorily. And effectively it's been split into 2 parts for those 2 periods. So for the first 3 months of the year, the 9 CCGs existed separately and therefore needed to do their own set of statutory accounts and reports. And then for the second period of the year, the second 9 months of the year, the ICB existed and needed to do its own statutory accounts and reports. So I'm going to take, so I've got 2 reports then today to present. I'm going to take them both before opening up to questions, if that's okay, Chair. So the first one sets out the process that we have adopted to produce and report our annual report and accounts for the 9 separate statutory CCGs. We produced draft versions of each of those documents in April, by the end of April deadline. The last 2 months then, those documents have been audited by our external auditors, and our audit committee has been updated and regularly reviewed at various points during that process. On Tuesday, the audit committee received those reports and the final external auditor opinion on the content of both the annual reports and accounts for each organisation. And this paper sets out the process and some of the key issues to highlight. But essentially, I'm asking for the board today to approve the 9 annual accounts and reports from the 9 statutory CCGs for the first quarter of this year. And because the process is very similar, I'll present the next report and before opening it up to questions, if that's okay. So the next report in the pack sets out very, very similar format, but essentially for the 9 months that we've been an ICB. And within this paper, you'll see that we have, again, submitted the draft statements. The audit committee members and board members have received a detailed briefing, or the opportunity for a detailed briefing on the format of ICB accounts last month, I think it was. So we went through what the statutory requirements are for NHS organisations and particularly for the ICB in production of its accounts and report. We also have again discussed the accounting policies, the annual reports and the accounts at our audit committee earlier this week. And they also received the internal and external reports, and the audit committee ratified the accounts on behalf of the board. So the board today are asked to receive the audited accounts annual report and to support our submission of those tomorrow by the deadline, and just to recognise the work that's gone into this. Is it 10 sets of statutory statements and 10 sets of audits that we've carried out over the last couple of months. So I'd like to just also thank the governance and the finance team for all the work they've done pulling this together. And I don't know if Neil wants to say anything on behalf of the audit committee, because we considered these in length earlier in the week.
Yes, just to comment, the 9 CCGs, I think we should say well done to the former CCGs and the existing place directors, many of them an associate finance director, who were there because they handed us quite a clean bill of health. There's one qualification on the World CCG, which was not significant in technicality in terms of issue. And also in terms of the internal audit issues that were passed on from the CCGs, all had recommendations and actions in place. So to be fair to the 9 CCGs, we should say thank you to them because their handover has been quite exceptional. So thank you for that.
Yeah.
In terms of the annual accounts, clean bill of health for the ICB and 9 CCGs, quite exceptional that in terms of the workload and with the changes in the handover. So I think credit fair dues to Claire and her team, and also Matthew there supporting us. They've done an excellent job to get us in this position. And the auditors, the work they've done with the auditors, internal and external, the relationship's excellent, which also helps. So well done, Claire and the team.
Thanks, Steve. Any questions, Steve?
Well, again, thank everybody for the work on this. And when you read the report, how much we've actually achieved, I mean, it was very difficult establishing the CCG and establishing this new organisation. When you look at the report, I think we can basically say we've done that and taken all in our stride. I know we've got lots of challenges coming our way, but I think we know the foundation of the first year. Just a question on the accounts, Claire. In the 9 months, the turnover is £4.6 billion. Notice we have a healthy surplus of 12.7 million. What happens to that 12.7 million? Does it remain with us? Is it rolled over, or does it go back to the centre? Because every penny will count in future financial years, I guess.
Yes, so as a separate statutory body, the ICB didn't draw down all the allocation available to it. But alongside that, during the same period, our NHS providers had a net deficit across them. So overall, the system achieved a balanced position, but the ICB position was a surplus. I think there the potential for a further drawdown of that allocation in future years, subject to certain conditions being met. And we're still working with NHS England to determine whether we have been deemed to meet those conditions given the deficit in the provider position for the same period.
Thank you. So if I could move us to the recommendations, firstly to approve the 9 CCG annual reports and accounts for submission to NHS England. People happy to do that? Yeah. And secondly, it's to approve the annual report and accounts for submission to NHS England. That's the ICB annual report and accounts. People happy to do that? Thank you. And I'll echo those thanks to the governance and the finance teams for a fantastic job. Thank you. If we can go on to the primary care strategic framework update. Claire?
Yes, thank you. So again, I'm going to do a very short introduction and then hand over to Dr. Jonathan Griffiths, if that's okay. So this item covers 2 very important documents and work programmes for the ICB. The first is our primary care strategic framework, which we've developed to inform the future planning and commissioning of primary care services across Cheshire and Merseyside. We did start work on this some time ago, but we knew the national document was coming out, so we sort of waited to make sure that everything we were doing was aligned and triangulated so that our priorities connected with those that were coming down from NHS England Central. Our strategic framework currently covers general practice and community pharmacists. Obviously, you'll know we took on responsibility for community pharmacy last July. We're going to develop it further to include our plans and strategies and strategic vision for primary care, dentistry and optometry, and we took on responsibility for those services in April this year. So thanks to all involved in developing the strategic framework, we've engaged widely with primary care contractors, the public through our Health Watch colleagues, so thank you for that, and wider stakeholders. Dr. Jonathan Griffiths, Associate Medical Director of Primary Care, will outline the strategic framework in detail. Particular thanks to him and Chris Lees, our Associate Director of Primary Care, for all their work in its development. Also attached to this agenda item is a helpful presentation which details, in summary, the National Primary Care Access Recovery Plan and our requirements as an ICB. So the document was published nationally just over a month ago, and I think we're making good progress against the very tight deadlines and timelines and deliverables. So I'm very happy now to hand over to Jonathan to give us a bit more detail, and obviously Jonathan, I'll answer any questions. Thank you.
Welcome, Jonathan.
Thank you, Chair. Thank you, Claire. Good morning. My name is Jonathan Griffiths. I'm a GP and Associate Medical Director for Primary Care. Claire's done an excellent introduction there. Just a few words from me. I'll take the paper and the presentation about the Primary Care Access Recovery Plan as read. I believe primary care is the beating heart of the NHS. So about 90% of all contacts in the NHS take place in primary care. And we need to place primary care front and central within this area of Cheshire and Merseyside, and I think this framework will help us to do that. If you think about when people talk about their contacts with the NHS, they will talk about their consultant, their gastroenterologist, their cardiologist, but they will talk about their GP as my doctor, and their optician as my optician, my dentist, my pharmacist. We have a connection with our population, with our patients. They recognise that, and they deserve good access and good quality of care from these primary care services. What we've tried to pull off here is a strategic framework that is detailed enough to define and describe our position at Cheshire and Merseyside, while being high level enough still for places then to develop their own strategies to meet local need. We've undertaken a lot of engagement to get this far. As Claire has said, we have produced the first 2 chapters only, so general practice and community pharmacy, and more work needs to be done now with regard to dentistry and optometry. We've engaged with a number of GPs and pharmacists. We've had face-to-face meetings, we've had online meetings. We have engaged with local medical committees, local pharmaceutical committees, with Health Watch. We've put questionnaires out to practitioners, both in community pharmacy and also in general practice. And you can see some of that reflected within the format of the framework. The result is, as you have seen, it's a big document, I accept that, but I hopefully will find it easy to read because of the way that we have structured it. So there are a number of topics. And each topic, essentially, for most of them, has 2 pages. The first page describing our ambition, the background, links to relevant guidance that we might have. And then page 2 is a more bulleted list of important actions that we think we should take, either as a system or a guide for place-based plans. The topics cover service development topics such as commissioning and contracting, population health inequalities, improving access, quality performance, assurance and safety, and the role of the GP or the community pharmacist. And then there are enabling themes as well, so integration, partnership working, workforce and organisational development, infrastructure and intelligence, working with patients and research and innovation. So I would commend the framework to you, and there are a number of asks for the board to note and comment on the content, to note and comment on the engagement that has occurred, and to highlight to us any gaps that you perceive there might be there. To approve the first 2 chapters and to approve the development of chapters 3 and 4. Also to approve a work plan is developed, and then also to note or request that we return. I put 6 months, that may be ambitious. I want to say actually thank you to the Innovation Agency who've undertaken significant work and support in bringing us to this point, but that period of support has ended now, so we don't have Innovation Agency helping us to do the dentistry and optometry chapters, so we can try for 6 months. It may be a little bit ambitious, particularly bearing that in mind. Briefly on the Primary Care Access Recovery Plan, we can run the presentation. My intent is not to because of time, but please say if you would like us to go through it. You've got it within your packs. That covers, you will see, 4 main pillars: empowering patients, implementing modern general practice access, building capacity, and cutting bureaucracy. We have senior responsible officers for each of those 4. You can see in the presentation how we are approaching this, and we're intending to return to board in, I believe, November to update you on progress on that plan. Over to questions. Thank you.
Thanks, Jonathan. It's really well summarised. I guess it was a long paper. It hurt my head as I was flicking through it, but it was really well explained. So, I want to seek comments and views around the table. Ian? Oh, sorry, I'll go Adam, Ian.
Yeah, I really support this framework. I want to say thank you to all who've worked so hard to put this together in such a collaborative and engaging way. That's been the case from the start, so thanks to Claire, to Jonathan and to all the team that has responded and worked on it. I've got a few brief points to go through. Most cover both documents, actually, because there's a lot of cross-cutting in them. But if there's specific ones, I'll try and call them out. It mentions in the framework a lot of core funding for primary care is nationally determined. I think it's really important that the lobbying mentioned in that strategic framework document for both pharmacy and general practice to start with, and then obviously the other disciplines as they come through, is heard by the central team. So I think the lobbying that the ICB can do is heard. We've seen the effects of the current funding arrangements play out, many pharmacies being unviable to continue. We've had the news of the reduction in pharmacy estate by Lloyd's Pharmacy and Sainsbury's. We've also heard yesterday that Boots are going to reduce their footprint by about 300 pharmacies in the UK, which is about 15% of their estate. And that's funding and unviability in healthcare. So that will likely have an effect in Cheshire and Merseyside, and I think our petitioning will be really helpful. I think there's an awful lot in this plan, this is my second point, that supports nationally commissioned services, and that's really, really great. Where we've often not quite got it right is the communications elements around that, and I think that's called out, so I was really pleased to see that as we progress through, particularly in the pharmacy first elements, which is the umbrella term for common conditions, expansion of hypertension, and start-up of contraception service that we've piloted here in Cheshire and Merseyside. I think getting clear communications with the public will be crucial to allow people to utilise those services and us to gain the benefit in the right way. There is a local commissioning element, so that local commissioning to allow wide schemes to stand up and to allow patients to get the benefit. I think we're doing some work on harmonising our minor ailments service, which we'll hear in the future, but there's also some more locally defined schemes to meet individual needs, and the strategic framework allows that, and I was really pleased to see that element in it. And I think the last point I wanted to make was we've heard an awful lot around inequalities and deprivation this morning. Some of the things that we haven't quite leveraged to the benefit is community pharmacy bucks the inverse care law. There's actually a study that was published about a decade ago now in the British Medical Journal called the Positive Pharmacy Care Law, which shows that 90% of the population have access to a community pharmacy within a 20-minute walk. And actually that access is greater in areas of the highest deprivation. We haven't leveraged our community assets yet to really bring the benefits in tackling health inequalities, and this framework gives the opportunity to do that. So fully support the work. I really look forward to contributing to the other chapters to come in the future as we go through the Primary Care Forum and the other parts of our governance. So thank you.
Thanks, Adam. I've got Ian and then Naomi, and then Tony.
Thank you, and echo Adam's comments there as well. It was just really just to thank you, Jonathan, and the team for the approach, because it's had population health and prevention strongly in the framework, and it's not even having to have that conversation, it's weaved right through. That really helps with when we're doing our population health boards and with the local clinical directors as well, so totally commend it and great to work with you on it. Thank you.
Thank you. Naomi?
Yeah, obviously just to echo, I think so much work's gone into this, and I think both from a general practitioner working on the, on the front line, but also I think from a patient perspective as well, you can see that there's the kind of consideration for workforce and for patient care, and I think both of those are really important. I think there was just a couple of points. I know we'd already discussed. I think what I've taken from this is that actually this is not primary care in isolation. Actually, in order for this to be able to work, we need to have collaboration across the system, and that includes both in secondary care, it includes with social care, community services, and I think it's really important that we have those communication channels, and that we have other system providers on board with this plan. So I think that primary secondary care interface is really important, but also to bring in other organisations as well. I know I've said before about my my concerns over the focusing on patient access. We could, within general practice, we could offer 3, 4, 5 times the number of appointments. It wouldn't actually necessarily meet patient demand, and I think I was looking at section 1.3 where it looks at access capacity and sorry, I've lost it now. It's looking at access and capacity, but I think what I would also potentially be wanting to look at is the quality of the appointments that are being delivered and the appropriateness of those appointments being delivered. So actually, if I've got a patient who can access, has improved ability to access an appointment with me, but actually it might not necessarily have needed to be an appointment with a GP. They could have been signposted elsewhere for more appropriate care, and we go back to that right place, right time, right person. And I think actually being able to use our digital capabilities to enhance that, and I know that is mentioned in the report. But yeah, I'm intrigued to see how we could, what outcomes we can kind of measure from this.
Thanks, Naomi. John, I'll come back to you at the end if that's okay. Tony?
Thanks, Chair. I welcome this, Jonathan. It's a good, solid framework, and I don't think we can disagree with any of the aspiration in there. What I would say is primary care thrives at place, and I mean that in its wider sense. I just don't mean general practice. And if you go around, talk to places as you do, you will know that obviously they'll confirm a lot of these things are it's our aspiration and some of the things that we're trying to achieve. I think Naomi makes an important point about the integrated approach across in terms of how we deliver some of these services. And one of the things I would say is that in terms of primary care, we've got excellent reach into some of our most deprived communities just by sheer number of the volume of providers that we have. And if I could correlate that to some of the ward data that I put up before, just thinking about community pharmacy is really accessible in some of those communities. So how do we empower them more? it's general practice plus other colleagues in that space. And I also agree with Naomi's point around people accessing the right care at the right time with the right person, and that forms part of the work that we're trying to do in terms of the same day access that I described earlier as well. So yeah, but support this.
Thanks, Tony. John?
Thanks, Chair. Just picking up on what a couple of colleagues have said around the opportunities of digital to support both the framework and the plan. You can see in the documents digital features heavily, and there are real opportunities there. So what we're proposing to do is provide a sub-strategy of our main digital and data strategy that describes our ambitions for this agenda, probably on the same timeline as the full plan, to set some ambitions around adoption of technology and to help colleagues working in this space make sense of lots of offers, because there's lots of technology offers that we need to take a fairly forensic look at what can add value. So we'll be bringing that back with on the same timeline as the full plan. And just to illustrate, in terms of that adoption, that ambition to have the NHS app as the front door to a number of services and relieve pressure, our current we've currently got 52% of our registered patients who have registered to use the app, which is quite good. And attached to that, 47% have access to their primary care GP record. So we want to set some ambitions around use and quality of service behind that, and then bring that back through the appropriate governance.
Thanks, John. Point to Warren, and then Paul, and then Claire.
Warren Escudero, Voluntary Sector North West and the VCFSE rep. Thank you for all the work on this. It looks really good. I absolutely agree with you about the building blocks of how we create a new health and care system. And for me, the health neighbourhood is absolutely the place where, if we don't get it right, nothing else will work effectively. There's good mention of population health, I think Ian mentioned, and I think that thinking through the links to place is really important. What we're seeing is, in terms of partnership with local community organisations, voluntary community organisations, it's very much hit and miss. There's some really innovative pieces happening. There's some places where the relationships are breaking down. And we've seen pilot pieces of work where volunteers have come into practices, used their databases and their telephone lines, and got a 71% increase in screening uptake rates for people who hadn't turned up the first time round. So there's lots of innovation, and I think it would be good to flesh out and work with you on this about how we would work through what a good model of working with the local voluntary community sector would look like. For me, that's a gap in it's in there under community partnership, but it's not fleshed out in the detail or on the ambitions that I'd like to see. But that's my perspective. But thank you for all the work on it.
Thank you, Warren. Paul? Some? Yeah. Perhaps open the doors. I'm not sure about the windows, but can I go to Paul?
Thanks, Chair. Like everybody else, I welcome this, demonstrating the full breadth of primary care and the challenges that it has. I've got to say I particularly welcome the approaches around reducing bureaucracy, and I also see it as a bit of a manifesto for getting extra funding into the system and getting into some of the challenges that are faced, not just in GPs but pharmacies, as Adam's referenced, and particularly dentistry, which is pretty dead as far as the NHS is concerned. So bringing that back to life, that's got to be a huge challenge. But my question to Jonathan is about how this has been received so far, particularly by practitioners, and what the buy-in to this is going to be. Do you think it's going to be seen as a positive way forward? Is it going to get support for the way in which we're trying to achieve improvements in health across the whole system?
Thanks, Paul. We'll come back to you, Jonathan, at the end. I've got Claire and then Rowan.
So just very briefly, in terms of, so thank you for all the comments, and I know Jonathan will answer as many as he can, or I might dip in a bit. Just in terms of, I suppose, the reporting back, so the National Primary Care Access Recovery Plan is reporting heavy. Not surprisingly, there are a lot of metrics, lots of, we're asked to report back. So we will do that through the System Primary Care Committee, which is our assurance committee for both documents, really. So we can do that, and obviously through Erica's sort of chair report, to give some highlights on that. And I think the key thing for, we've got the pillars, the 4 pillars, but it's the cross-cutting themes. John's talked about digital. We've had a conversation previously today about workforce, obviously population health and finance. So I think there's an opportunity with the National Access Recovery Plan and our strategic framework to really sort of triangulate and align some of that work. But I think it's just key, so we'll bring back the national plan, response to the plan in November. But obviously through the System Primary Care Committee, we'll have that regular updates and reporting, and we can bring some sort of progress metrics to the board as well. Thank you.
Thank you, Claire. I know it's in the report, but it's worthwhile noting, given the currency where we are at this moment in time, there's also an enabling strategy about estate.
Yes, and there's work already started on that across all estates, but primary care as well. And I just wanted to, sorry, Paul, just in terms of dentistry, we did receive a dental improvement plan at System Primary Care Committee last week, where we're looking to increase activity and access around some of our most deprived areas. So there's quite a detailed plan that System Primary Care received, which we're looking to invest back to £5 million in dental access.
Thank you. Rowan and Hilary.
Thank you. I guess one of the crucial things to make this succeed goes back to one of the first comments you made, Jonathan, is that the relationship that patients have with their doctor. And for us to really make this succeed, and we've discussed the enablers of digital, what this distills down to is our ability to make a really meaningful contract with our communities that says your primary care service needs to work smarter, not just harder. And that therefore we take our communities with us with really strong engagement and communication, so that the access to different healthcare professionals becomes the norm, becomes something that is comfortable and gives our patients confidence. So the need for this to be communicated so thoughtfully, I would offer, utterly underpins our success with this. Thank you.
Thanks, Rowan. Hilary?
I just want to talk a little bit about leadership, and it's great to see the PCNs mentioned here and the development of them. But I just want to really promote the fact that this is multidisciplinary, so it's my doctor, my nurse. And how do we now create that pipeline of leadership where nurses want to become PCN directors? We've only got 20 nationally, and they fall off really quickly because they're not being given the time to do it. So my second point is, how do we support our practices to be good employers? I think the second thing about there's great emphasis here on research and innovation. Please, can we make that multidisciplinary from the start? I know we've got two great new appointees who are in the medical directorate, our research and champions. If that whole team could be multidisciplinary, that would even make it better. And I think my third point is making general practice attractive, and having our HEIs behind this and really encouraging non-medical staff to go into primary care is absolutely essential. Those nurses that go into primary care as their first career choice are those where primary care has been absolutely amplified by their tutors, their professors in universities. So I would ask that we work with our HEIs to make sure that they amplify this and really get behind it as well. My final point as well is let's learn from those practices where other professionals are practice partners as well. There's about 5 or 6 practices nationally where GPNs are also practice partners, and they are thriving. So maybe some lessons to learn from there as well. Thank you.
Great point, Hilary. Jonathan, I'll come back to you, the opportunity to say some concluding comments.
Yeah, thank you. So I really welcome those comments and some of the challenges there, which I think we would want to take take on board. Not necessarily in the order that you said, but I've made a few scribbles. So I think you're right. So a number of mentions about communications and how we get this across to the public, I think, is absolutely key. You'll see that that is in the document. It's also a large part of the Primary Care Access Recovery Plan. We've been told there's going to be national campaigns around communications describing the relationship between general practice and the public. So it's different, isn't it? When I started as a GP, the offer was the GP or the sister. And that was it. And now it is the GP. Is it a partner? Is it salaried? Is it a GP registrar trainee? Is it the practice nurse? Is it an advanced nurse practitioner? Maybe it's the physio. Is it the clinical pharmacist? And the list goes on and on and on. And people don't understand that. And we need to get across the fact that if you are offered an appointment with the physio, we are not fobbing you off with the physio rather than the doctor. We actually think that you need the physio and you'll get a better offer first time through that physio appointment, and we could use other examples as well. So absolutely. How do we measure this? How do we demonstrate that there's been improvement? We're wanting to develop a work plan from this that has got some smart objectives, and I think that's part of this. I think there's a challenge as to how we demonstrate improvements for patients, and some thought needs to be gone into exactly that question. Place, Tony, I think Place needs to deliver a lot of this, and it also then links to the question and challenge from Warren. Very much would welcome working with the voluntary sector on this as a question, I think, for us all as to where does that fit best? Does that fit best at a system level, or does that fit best at a place level and in local communities? Or is it a bit of both, I suspect what you would say. But absolutely would welcome working with you on that. How do we get buy-in, or is there buy-in? I think there is a desire from practitioners on the ground to do something different. The challenge is they're so nose to the grindstone at the moment, it's very difficult for them to lift their heads up and see what could be different. So we need to work and offer those opportunities to say, actually, you could do this, you could try this. Here's an offer. There are a number of actions within the document that I think are offered to primary care. What we really need to do is to deliver on those, because what they will say, I think, right now is we have seen strategies come and go in the past and nothing ever changes. So the challenge to us is to make this real, to make this work, and then I think we start to get buy-in from those on the ground. Thank you for the challenge about nurses. I would agree. I think we need to think about that and whether we can bolster the document with that regard. So with PCNs, I think of our 51 PCNs, we have one non-GP as a PCN clinical director. They're a community pharmacist in Knowsley. I don't believe there are any nurses who are PCN clinical directors. I may have not understood that. So I think that's right. To how do we promote a more multidisciplinary model of leadership and how we work practice around that. So I think we'll look to see if we can just sort of shoehorn that in a little bit. We have now got a primary care workforce steering group. So some of the questions and the challenges, I think, relate to how we use that group to make Cheshire and Merseyside primary care a desirable place to work. So how do we pull that off? And that will be key to bolstering our workforce as we go forwards. I think I've covered off most of the thing I was going to say is that there are a few tweaks that will need to be made to the document, partly on comments that we've received today. Partly I had some late comments coming in from Health Watch and some others that we need to incorporate as well. So just bear that in mind when you're considering approving where we're at the moment. Thank you.
Well done, Jonathan. Final comment from me, it's really to the exec. We, of course, will see in due course an investment plan, won't we, to understand what the financial consequences and investment profile will be to support this really significant plan for us. Jonathan, I'm not going to try and attempt to summarise all the comments here. Louise has ably captured them, and we'll pull them out of a minute to make sure the details there. But the board is asked some specifics here to note the paper and note the engagement. We're asked to approve the first 2 chapters of the framework. We have heard some comments, haven't we, about probably points of emphasis and some additions that we need to see incorporated in those chapters. Claire, I'm going to look to you to make sure that the board's wishes have been incorporated in those 2 chapters. Of course, yeah. Yeah, so the board can seek the assurance through that route to get to that route of approval. Approve the ongoing work and development of chapters on dentistry and optometry, and approve the development of a work plan based on the framework to inform ongoing plans and note the final framework with chapters brought to the board within the next 6 months. And we need to see the financial support, that's the financial strategies that will be associated with that. Okay, thank you very much. If we can move on to winter debrief, Tony.
Yep. Thank you, Chair.
Anthony, should I say?
So hopefully the paper is an easier read for what is a highly complicated subject matter of urgent care. But the paper sets out to demonstrate our approach and the findings of our winter debrief process that we previously reported to the board that we were underway. In some respects, it picks up on some of the response and the plans that we picked up through the operational planning round for 23-24, and then moves into our priorities and our governance for the urgent care improvement programme that we've established at ICB level, ahead of our efforts to make winter a better experience than the one that we've already had. I'll pick up on a few salient points, I guess, in terms of how winter played out for us across Cheshire and Mersey, which was not necessarily out with the national position, but there was degrees of certain factors that showed themselves more prominent in Cheshire and Mersey. So one, and Neil's already picked up on it early on, was the very high bed occupancy that we had running into winter. And what normally happens around just before Christmas is we normally see a de-escalation of acute bed occupancy in the week or so beforehand, and that simply didn't happen in Cheshire and Mersey this time around. So we went into that Christmas and winter period with our highest rate of occupancy and our highest rate of non-criteria to reside, those patients that would be looking to be moved on to social care settings or home care settings. The figure at that point was 25% of the entire bed stock was taken up by non-criteria to reside as we went into Christmas. The normal seasonal demands that we would expect to see, respiratory conditions, were high and above previous years, and it was also exacerbated by a much publicised prevalence of strep A, which caused some real challenges on the system, particularly in paediatric services. And what was increasingly notable was an increase in lower acuity attendances across all sectors, something that begs questions about how some of the services are being accessed. We don't often talk about COVID in the sense of the pandemic is effectively formally closed down, but we are still seeing seasonal waves of pandemic occupancy in our acute hospitals. It ranges between 2 and 7% through various waves. We hit the peak of that 7% wave on the 29th of December as well. Therefore, it created a very challenging position going through, and as you can see through some of the metrics, how that played out in terms of corridor care, ambulance response times, bed occupancy, etc., etc. And what I'd stress is that in some of these cases it looks very acute focused, but as we tried to bring out that through mental health and various other sections, the pressures were extremely high across every single sector that we looked at and debriefed upon. As I said, to some extent, the Cheshire and Mersey position was not out with the national position, and we saw just after Christmas a national recognition of that, and additional funding was released to try and create some additional social care capacity at short notice. We utilised that money across the Cheshire and Mersey area, and that did increase capacity and help mitigate that risk as we went through January and beyond. I won't look at any more details, but it is contained within the paper. You can see yourself the debrief process findings. One of the things that I will pick out from there is some of the feedback that came back from providers, in that we are getting money on a regular basis, but it's coming at such short notice and for such a limited period that it's really difficult to manage what is an unplanned set of events. But one of the things that was recognised moving into 23-24 is that nationally some monies that were made available to us last summer around increasing acute capacity, which totaled 206 beds across Cheshire and Mersey, that was made recurrent. And the process there is that, or the theory behind that is that you still need that capacity in place during this year as you work upon the improvement processes that are necessary to allow the reduction of that capacity at some point in the future. What the paper then goes on to point out is the UEC plan. Some of that is the national UEC plan. It's a national NHS UEC plan, and you can see the main 3 themes that come out of that. I guess, you know, we would all recognise those, but what, as Neil probably raised earlier on, you know, we've had national discharge team visits, we've had the emergence of the urgent and emergency care tiering system, and it all points to what we already know is the greatest priority for the Cheshire and Mersey system, and it is that disproportionately high level of patients that are in the acute sector that require care outside. Now that position, probably just to jump to one of your answers, Neil, has improved. You know, we're in the 18.7% as of this morning, but it's still out with the England position of about 14.5 at this point in time. So we have implemented the programme. We've put some governance in place to cover all of the urgent care, but to focus specifically on that discharge as our priority work stream, and that's set out within the paper. We are receiving national support around some of this programme. We're being very prescriptive about what that national support should comprise of, and only last night I was contacted by the National Director to say that some of that work that we've requested in terms of demand and capacity analytics of the social care to secondary care will be forthcoming. So we'll work on with the national team around that. Equally, it comes with a high level of scrutiny. So across a number of work streams, we are having to provide progress reports on a fortnightly basis with our national colleagues around that. But, you know, that's fine, and it works both ways, so it's great. I won't necessarily go into any more detail. I'll turn that over to questions. What I would point out is that the construct of the programme, particularly around discharge, we very much recognise the need to have co-production in the detail around that. We have looked to incorporate local authority leads, place leads, the acute sector and other system leaders. Warren and his team are indeed involved in that programme of work. In terms of your precise question around trajectory, Neil, we've set ourselves the ambitious goal of 10%, and that probably is a trajectory through to the end of the financial year. One could question, is 10% ambitious enough? What I'd say is that the national ambition is 12. And there's only a very few systems currently operating at that 12% margin. That's the goal that we're setting ourselves ahead of winter. That's tied into our objectives of this work programme. But we're highly cognizant that it's one thing setting an ambition. We absolutely need the input from the players that will be delivering that will help us construct it. The one thing I'll finally say is the programme's all well and good, but we're highly conscious that you can't just point to this programme for the day-to-day delivery and management of urgent care. That absolutely has to be there, trying to manage an unplanned series of events and factors. Tony gave some further assurance early on about how Halton managed that in terms of the operational plan focus. And we've seen real issues in certain parts of our system where turning the focus very much at the most senior level within the patches has really had impact at a relatively short period. We've got real variation, as you probably expect, on this ICB footprint. So when we talk about the headline of it's at 18.7%, we've got ranges between 14 and 24 across the patch. But some of those outline areas have shown some improvement in recent weeks. But it's a real-time and very demanding process to keep on top of. I'll pause there, Chair. If that's okay.
Thanks, Anthony. Can I just ask a clarification, Anthony? I might have heard you say this, which is something like, by the start of winter, so 12, 13 weeks away, all our 9 places will be at 10% of no criteria to reside. Is that what?
No, I think what we recognise is that within the plan there are probably short and medium term objectives based around 8 and 12 weeks. Our maths at this point is that we believe that will take us to about 12% going into winter, which would put us in the highest level of performance across an ICB, and certainly half the position that it was last year. To contextualise you, that's a 600 bed change. We recognise that there are longer term achievements to be made, which is very much about addressing...
and can I just ask you to stick on this short term? Because we're not far from winter, are we? So 12% in each of our places, and I can't see so I can't see what tangible changes have happened to enable us to be assured that that 12% will be achieved.
So there are additional capacity in. There's a change of governance. There is a real fuller understanding of capacity, and what we're focusing very much on is the processing to access that capacity. So in-hospital processes, consistent discharge to assess basis, trusted assessor processes that are in place, and we're just trying to streamline the processing because the capacity is probably there. It's just the time it takes to get to that point. And whilst it might not be the detail, might not be in here, Raj, it's the detail that we pull in through the programme. We're giving updates to the quality committee as that result, but we can fetch some more detail back here or a deep dive on it at some point in the future.
Right, well, we'll come back to that.
Yeah.
I think, Rowan, would you signal? Yes?
Thank you, Anthony. I sincerely hope that we prevent a number of admissions as well with all the work that is going on, whether that's in heart failure, COPD, to prevent people coming to the front door in the first place. So I think that's going to be really important. I hugely welcome if there's going to be some additional support to properly map what assets we've got to get patients out to in social care and what the offers are. We keep getting this sense that there's a mismatch of supply and demand around the right sorts of packages of care, that we have beds in care homes, but that's not where we want to get patients. We want them to get back to their own home. So I really welcome there's going to be some support on that. The one bit of this pack that jumped out at me that I thought I wasn't expecting to see that is 4.6, which is the mental health patients, which for colleagues is on page 247. Where everything else appears to be improving post-winter, our mental health patients treated in emergency departments is going in completely the other direction and actually has deteriorated through the spring. Is there a particular narrative that goes with that and a set of actions that follow? Thank you.
Well, I think, in fairness, Joe probably covered some of that earlier in terms of that recognition of the capacity constraints within the mental health service provision, but also very much about how those patients return back to a social care setting. It's the same issues that exist in many cases across acute discharge. The numbers here, obviously, deeply stressing for everyone involved, but the graphs are in single-digit changes, aren't they, from one period to the next. What we have done as an ICB is that we've stepped up the operational processes through the system control centre so that in the morning, where there's been that traditional focus on acute occupancy and challenges and discharge, there is now a similar process taking place at 2 o'clock every afternoon with all the mental health providers, and it takes on a wider footprint with some of our other ICB colleagues to understand how we can make best use of the capacity and expedite and prioritise patient discharge from the mental health provision, which only backs up one way back into the ED as well.
Thanks, Rowan. Neil?
Yes, thanks for that.
Sorry, I missed who we are.
Sorry.
I think the two biggest challenges we've got in ICB is the financial stability of our providers. Question was talked earlier about, where's our £12 million surplus? Well, it's gone to support providers. And we've got a financial and clinical strategy in place, and that's being worked through, so I've got confidence of that. The other biggest challenge is the discharge. And I know it's going through quality, but I find it helpful maybe in October, November to come back with what's worked and how it's worked by different places to see if there's learning so that we can understand how successful it is and how we can actually support or whatever we need to do. And my final question is that one on the virtual wards, 55% occupancy. Is that good value for money? Is this part of the plan that will be used more?
I don't feel I don't want to drop you in, but you're okay to field that one.
Well, so either Claire or I can talk about that. So yes, recognise that 55%, although it is an improvement to where we were a couple of months ago, it still looks on paper to be quite low. I think the national team have recognised that we were perhaps ambitious in our plans for virtual wards. And so we've been working with our virtual ward programme to do a complete review of
their trajectory and the pathways that they're putting in place, but alongside that, working with Claire to really look at the finances and make sure and look at taking some of the money out of virtual wards to make sure that we are getting value for money. And the virtual ward programme are on board with that and supportive.
Thank you. I've got Hilary, then Naomi.
I was just going to think, if we could get people to think differently about virtual wards. If we had 150 beds, we looked at that, if we put a tent up in a field, 150 beds, we would fill them. So there's something about changing our mental model around virtual wards, which you've covered. My second point is IPC, the number of beds that we consistently have closed. I'll just take back to the COVID peaks, the first peaks. The IPC guidance was coming out by the hour, wasn't it? It was confusing, but we got to a point of clarity where people knew what they were doing. Then the second iterations of guidance came out towards the end of the acute period of the pandemic. And that became quite broad. And I think, well, I know nationally that was open to interpretation and confusion as well. So there may be some value in working with our IPC leads now to get absolute clarity on when it's necessary to close beds. So we start to reduce that potential unwarranted variation ahead of winter. You know, at the peak here, we're talking over 200 beds at the worst time. So I think putting that investment in now may yield some benefits. And so my third thing is that good discharge planning happens at the bedside. It's about good administration, good ward clerks, it's about good porters, it's about good pharmacists, it's about good healthcare assistants. How do we hardwire their hearts and minds into this so people know exactly what they need to do day by day to make every hour count for everybody that's stuck in a hospital bed? And just to change the mental model of this as well, is that I often think we are holding patients prisoners in hospital that don't need to be there. And if we can just, again, change our mindsets on what can I do today that will make a real difference to somebody going home. So there's something about really creating a momentum for every single person across the system. And I will probably challenge us as an ICTP to think how we can start doing that from today. Thanks.
Thanks, Hilary. Some great challenges and opportunities there. Naomi?
I know that this paper is meant to look at kind of urgent and emergency care, but I think actually we need to expand that view and look at the impact that primary care has on urgent and emergency care. And actually, if we look at prevention rather than by the time they get to A&E or by the time that they're admitted to hospital, you know, if a patient with COPD can't access a GP appointment, so potentially waits 2 or 3 weeks, by which point they've deteriorated to a pneumonia and then require admission. You know, actually, if we extrapolate that back, if they could have had that initial contact, then we could have potentially prevented that admission. Unfortunately, in general practice, a lot of the funding comes nationally and it comes too late. Just to give an example of last year, in December, we were given a 2-week turnaround to put together a capacity and access, a winter capacity and access to be able to improve patients' access to primary care. That had to be spent by the end of March. Actually, if we'd have had that in the September, we'd have been able to have had that prepared in place and have had an effective service for those patients, as opposed to something that had to be developed within 2 weeks. So to find the staffing, the organisation, all of that. So actually, I think if we, as a system, if we can push back and say, in order to impact this, we need that funding to come sooner in order to then be able to prepare for the winter, as opposed to a reactive fund that is sent too late. And I think that also then that also goes with the care providers. We know that there's an increased use of hospitals at home. There's an increased use of services such as ICRAS. Actually, we need carers for that. If we start recruiting now, then we can have the carers in place for September, October, when the numbers start increasing. So I think that this is much wider than a secondary care issue, and we need to look across the whole system at this.
Great point. Thanks, Naomi. Steve?
I want people to think there's not been Herculean efforts at place level systems around the no right to reside issue. I mean, the creativity and the effort that's been made. Difficulty is the care market is fractured. There are issues around staffing recruitment and retention, certainly in local government, and it's just not an easy issue to deal with. Now, I agree with Hilary about need to change the mindset, but one of the things we need to change the mindset about is obsession with beds. I made the point earlier about the disappointment of government not supporting the investment in prevention, particularly with frail people, keeping them out of hospital and keeping them out of the system, really. And that's really where we need to change our mindset around prevention and make the necessary interventions in terms of support and funding.
Thanks, Steve. Okay, so I had a conversation with Graham outside of the meeting, and it's really important for this board to be as assured as we can about our preparation for winter. And in September, I think we will hear from the executive team what those key issues are, what those key actions are going to be, and the assurances that we have that those key actions will be delivered. We've heard today some really important stuff. I know you as executive teams understand and know this well. So around IPC, how do we change mindsets? Naomi's point about system working, it isn't just about hospital beds, and we all know that. This board is an integrated care board, and we must see in that September plan a winter plan that's across the system. I'm going to just give you a personal reflection about national funding. So my time as a hospital chief exec, it can be important, but it's a little bit compared to the totality. And what we need to do is understand what we're doing with the totality around urgent care and how we're evolving that. So waiting for national funding, let's treat that as a gift, but our core stuff must be about what we're doing with our money today. Okay. Graham and execs, really, we've been trying to do this for years, haven't we? But we have opportunities in the setup of the integrated care board that we didn't have before. So September, yep. Anthony, I know you're going to focus on this. It's great. The analysis and the setting out and the planning processes and the learning that's come from the review, really, really important. But there's yet so much more to do, isn't there? Thank you. Can we quickly go on to North West Specialist Commissioning?
Yeah, thank you. So within the paper are the proposed recommended terms of reference. Brought these in March when we discussed the ICB working as part of a joint working agreement with the region and the other two systems in the North West, Greater Manchester and Langston South Cumbria. So we had the first meeting of the North West Specialist Services Joint Committee in June. I chaired that. I think it was, I didn't have my head down quickly enough when we were going around who was chairing that on behalf of the region. On that committee going forward with myself will be Claire, Fiona, our Associate Medical Director, Deputy Medical Director, and Neil. We'll also have representation from our providers, and I think we're having the Chief Exec of Alder Hay on behalf of the two provider collaboratives. So we will represent Cheshire and Merseyside, but on that joint committee, so on behalf of the population of the North West. So really today it's just to recommend the terms of reference to the board for approval, and to provide assurance to the board that through the Transformation Committee we will take reports on the delegation work we're doing, because we will be taking on responsibility for a large number of services from next April, and we'll bring reports back through the Transformation Committee. But for today it's to approve the terms of reference, please.
Thank you, Claire. Really important, but it's about terms of reference. People comfortable with that? Okay.
Thank you.
Thanks. Let's go on to Chris, Executive Director of Nursing Care, update.
Thank you, Chairman. So I just want to bring the board's attention to briefly to a number of points within the Director of Nursing report for this month. So it's already been mentioned this morning from the Chief Exec's report around the industrial action. I just wanted to highlight how the clinical cell has been gathering insight on respects of any identified patient's harm as a result of industrial action. We've established a tracker which is collecting any information should we receive that. The report also highlights and just mentions briefly that we did hold a lessons learned event, which was on the 20th of June. This was before the announcement from the Royal College of Nursing ballot on Monday of this week. And what we did there was a number of providers came together to look at lessons learned and how we made feedback both regionally and nationally. And I think those feedback points are still pertinent, even though at this moment in time there's no planned further action from a nursing point of view. The paper highlights the System Improvement Board process for both the Countess of Chester and Liverpool University hospitals, and it outlines that there's now an agreed set of exit criteria that needs to be achieved to facilitate the conclusion of the oversight assurance process. And we now have a process in place where we're feeding into the system improvement boards around how, as an ICB, we'll assure this exit criteria is met. Further point then around the patient safety incident response framework. I have in previous reports during the last year mentioned the PSERV, which is a nationally mandated process which would be required to be implemented by autumn of this year. We currently have one provider who has signed off their process for implementing this the PSERV process, and will commence on the 1st of July. And we have a timetable in place for sign-off and draft dates for the implementation for the remaining providers. And then finally, a section on special educational needs report, which the annual SEND data has recently been published. And I just wanted to bring to the board's attention that currently we have only had Warrington that has been inspected under the new framework. So we're working with the place director and team and local authorities to address actions identified and required. I would anticipate that other areas within the system will be inspected under the new framework in the coming months. And I'm happy to take any questions. Thank you, Chairman.
Thanks, Chris. Any questions or clarifications? This important topics, Claire?
Thanks, Chris. I think it's just to let the board know that a number of us have been undertaking place reviews over the past couple of months, and children's inspections has been a key agenda item on those review meetings, and I think we've had assurance from our place directors and colleagues across the places that, you know, really good partnership work's taking place, but there are risks. And I think, Tony, we had Halton's review earlier this week, and you're just waiting for the next SEND inspection, aren't you, in terms of Halton as a place. But just to let the board know, we have those place review meetings, and inspections and children's agenda has been high on the map.
Thank you, Claire. So if no further questions, comments, the board is asked to note the report and request any additional information. So we've noted that. Can we go on to the ICB Quality and Performance Update Report?
Yep, thank you, Chair. I think, probably just first to point out is what we've changed in terms of the narrative this month is just trying to put some of those sentinel metrics up front so that the board members can easily get cited on what they are. But we are working on a revision of how we present this this subject matter back to board, again, probably the timescale of September. But obviously some stakeholder engagement before we get to that point, Chair. I wasn't going to concentrate too much on the urgent care. I think we probably just covered that to some extent. And Graham mentioned some of the improvements that we've seen, or certainly where we stand in terms of some of our planned care, certainly the 65 weeks. We are ahead of the plan at this point in time, despite some of the significant impact of industrial action. And I think the same could be said really in terms of both our approaches to diagnostic and cancer. In terms of our operational plan for this year, we're just ahead of where we should be in terms of cancer backlog reduction. But there'll be variation within various tumour sites, but we have the diagnostic and the cancer network working well on that type of stuff. You probably heard earlier on, even from Joe's reference about the focus that we have on mental health out of area placements. And a reference just before how we're dealing with that operationally, but there's a more strategic plan needed to understand the capacity across Cheshire and Mersey around that. And I think the primary care demand is very apparent. and I think Jonathan's pointed us towards some of the longer term solutions to that. So I wasn't going to necessarily draw too much more out from there and just open it up to board members. I think some colleagues may want to pick up on some of the key elements as well. I think Fiona, you wanted to mention one particular element.
Thanks, Anthony. I most certainly found, the pulling out of central metrics, that was really helpful. Fiona?
Thank you, Chair. I just wanted to look at the learning disabilities health checks in section 6 and acknowledge the fact we have discussed that at this board before, and acknowledge the work that practices and teams have done to get to the 80.4% by year end. I think the next thing we need to do is look at, well, so what did we do that got us that 5% beyond target? How evenly distributed is that across our practices, and what can we do to support the practices who weren't making the same improvement, but just a positive?
Yeah, it's great news. Thank you. Tony? And Paul? And Neil?
Thanks, Tony. We have discussed this, the learning disability data at great length and quality and performance. What we didn't discuss, and it's shown up here on your mental health report, is the increase in physical health checks for people with severe mental illness, which you said fell short of the target. The targets aren't in there, so how big a shortfall is that, and what particularly can we do to replicate what's happened with learning disability health checks?
Really good point, Tony. Thank you. So Fiona nodding ahead, so you're accepting that challenge, I think. Yep. Paul?
Thanks, Chair. I can support Tony with those comments. We've done a lot of jumping up and down at quality and performance about learning disability checks, as I have done locally in Sefton. So it's good to see that. And yes, we need to improve the mental health situation. Just a few comments on performance. So overall, the ambulance handover times, it's really disappointing to see those going in the wrong direction in June. It's really disappointing that we just had a winter plan that we've got corridor care in June still. That's a reality that really we've got to try and get over. It's incredibly distressing for people to be treated in the corridor. And also on mental health and the mental health beds. When I've mentioned this before about capacity and asked the question, have we got enough mental health beds? Well, I've been told, well, yes, we have, but it's all about getting the right housing and community placements for people, which is great. When are we going to see those? I mean, is there a disconnect here? We month after month we receive this information, and I hear from my social workers in Sefton saying that they've got patients who are desperately in need of a mental health bed, waiting for days before they can get one, because there isn't a single bed free across the whole of Cheshire and Merseyside. So yes, we need more, and we talk about, we need better community resource and housing. Housing is such a wonderful thing, but are we really working on that as an ICB to try and make sure that happens, so that we don't have so many people in real distress as they are at the moment? And again, it seems to be that this stat keeps coming back month after month.
Thanks, Paul. Greg, is there any immediate comment you could make on housing and ambulance?
So my comments on all of this is it's a very complicated system. Lots of partners with different responsibilities in the system. We all have to work harmoniously, because all of this comes back down to the simple point of flow. So we actually do better on ambulance handover delays than the rest of the country. Now, by making sure that we release the ambulances really quickly at the front door of our hospitals, because actually the patient at the greatest risk is the patient that somebody hasn't got to yet. That is meaning people are then spending longer in the A&E department, because the A&E department can't flow those people out of the A&E department into a hospital bed, because we can't flow people out of the hospital beds back to their own homes or other settings. And that's often exacerbated in mental health services because there's a higher proportion of people in mental health services who will not be going back to the home that they came from for you know, a variety of reasons. And we need to make sure that we are working with housing providers as much as we're working with our local authority partners, as much as we're working with the ambulance services and GPs. So it's a multifaceted issue. It continues to get the utmost attention, but it does feel like we are only nudging this forward, and at some point in time we need to get a breakthrough.
Thank you, Graham. Neil?
Yes, thanks, Anthony, for this. The report's really getting there now, turning the data into information that we could focus on, so thank you for that. I've just got one detail. I raised it a couple of months ago, and that's about East Cheshire's hospital mortality indicator. And I know work's been taking place there, but at that time when I raised it, it was at about 115. It's now gone to 117.2. So I'm just wondering what work is taking place and whether it's data quality, whether it's issues we need to be concerned to, and whether you can come back to the board at some point to update us on that.
Yeah, thank you. So two things are sort of happening in parallel at the minute. The Trust themselves have brought in a review from the Aqua team to go through their data and understand that they've got it right. And I have separately managed to get the resources in place to have to look to triangulate this using their heads and head data in a completely separately designed exercise. I'm waiting for both of those to come. The commitment from their medical director is that they will be at our June Quality and Performance Committee to take the committee through all of the detail of those findings. No, they didn't come in June because they hadn't completed the work. So the commitment they've made to us is that it will be at committee in July and will take committee through all of the detail.
Thanks, Neil. Okay, so got the report in front of us. Sorry, Claire, you've got a question.
No, it wasn't a question. It was just a sort of a link point to Graham's response about housing. To say that we agreed yesterday, Raj, that the September meeting of the HCP would focus on health and housing. And I think it's just important that we make those connections, and I'll speak to Anthony about it separately, but we just make those connections across the system. But I think it's important to recognise that in terms of it's one of our 4 top priorities for the HCP, so we bring it together, and I think that workshop will be helpful. Thank you.
Yeah, great point, Claire, thank you. So, board's happy to note the report with those discussions and comments that we've had so far. If I can go to the report of the chair of the Quality and Performance Committee.
Thank you, Raj. First point to make is under section 2, the LMNS maternity report. We get alternate reports of detail and a briefing report, but I must say the briefing report also contains an awful lot of detail. What we're receiving from LMNS through Chris's leadership is a very good level of accountability and a good sense of what's going on in the whole system. So at every committee meeting, we're gradually, I think, getting more and more confidence in that level of assurance. Patient safety report, Chris has already mentioned this. My comment here is just to compliment those working on the detail of getting this ready. So as a readiness report that we received, it's looking very good now. The catch-up that was needed in some trusts has happened. The standard operating procedure is well advanced, so I think we're confident that that important system will be implemented on time. The place-based quality reports continue to be very informative, and Chris has already mentioned SEND as a constant theme. We get regular updates on that, and that's positive. We've also received a good update on the delivery on the all-age continuing healthcare pathway, which is a continued focus for the committee. So if we move on to the issues of escalation, mortality reporting has already been dealt with, so Rowan's answered. I'll not go back to that script, but the committee also received an ad hoc report following an increase in never events reporting. So both of these illustrate the value of the committee in its surveillance report use, and actually then not just taking those figures as read, but actually undertaking further analysis, and compliment the clinicians involved in these of bringing that information to the committee regularly. As Rowan said, particularly on the mortality reporting, we're going to continue to look in detail at East Cheshire, but my point is that this has got to be a continued focus for the whole system at quality and performance to make sure we maintain that surveillance of all providers.
Thank you, Tony. Yeah. Now, can I just check that the never events of Countess of Chester will be included in the oversight around Countess of Chester? Yeah,
Sorry, at the next SIB there is a deep dive around the never events.
Thank you. Okay, people happy to note that report and those escalations? Thank you. Can we go to the finance report, please, Claire?
Yes, thank you. So the report sets out the financial position across our whole system for the end of May, which is month 2. It is quite an early point in the year. We only submitted our final version of our plan last month. So you'll see that we have an adverse variance against our deficit plan at this point of the year of 7.8 million. So we plan to have a deficit of 40 million, and it's slightly worse than that. But as I say, it is early days. I think the key areas that are giving us pressure at this point in the year continue to be inflation pressures, particularly in the ICB's own accounts around prescribing within primary care and continuing healthcare inflation. The impact of industrial action in our providers and some of the costs of additional pay to keep organisations safe during those days, and slippage and some delays on the delivery of our cost improvement programmes across all organisations generally. So just want to draw out 2 things then. First of all is an area of risk just to be aware of, and secondly an area of some good news, I think, within the report, which is always nice to draw attention to. So the first is the risk, which is, and you'll probably have been able to calculate this in your own mind, is the way the plan is profiled. So the plan is profiled so that we're assuming quite a lot of efficiency towards the back end of the year. And that's why when you'll know that we've got a deficit plan for the year of 51 million, and you'll have heard me just say that in the first 2 months of the year, we've delivered a deficit of 48 million. So effectively, that in itself has, an implicit risk within the way our plan is profiled, and that is something we're very, very mindful of. The second thing, and to just draw your attention to, is some relatively strong performance on our agency staffing costs, thanks to some incredible work across all of our NHS provider organisations. So even though it is early days, and we obviously have had some disruptive events around some of the industrial action, we are slightly ahead, expenditure slightly running ahead of plan, but only slightly. And our forecast this year is for our agency spend to be 119 million compared to the 155 million that we experienced last year. So I think that, that's some really good positive news story at this point in the year. So there's obviously lots of comprehensive information in the paper. I will pause there and take any questions or comments. Thank you.
Any questions or comments? Nope. Okay, so let's move to the recommendation, which is to note the contents of the report for month 2.
Yes, please. Thank you.
Thank you. Thanks, Liz. Should we go to the report of the Finance Investment Committee?
The policies across the ICB. So it was really good conversation, and that's going to come back to us. So it's containing that in effect. I think the first draft that came out to us looked a bit heady on what that might mean. So that's gone back now. So it's just a note for you all to know that that's what we've been talking about. The second one was what was really great. It was the first update of the ICB Workforce Committee. So it's starting to gain traction now. It was a real deep dive on what are the risks around our own workforce, and also looking at the performance matrix. So not only looking at them, it was the so what. So what are we going to do about it? So that was really good to come through that committee as well. So that's it from me.
Thank you, Erica. Any questions or comments for Erica? And it's to note. Thank you. Neil, could we go to the Audit Committee?
Yeah, just a couple of points really. One is we've talked about the annual accounts and well done there. Second is our anti-fraud annual plan has been submitted and that's been signed off with the Green, so we're doing well with that. I suppose one area of concern perhaps that we picked up and also in finance is about the number of ICB procurement waivers that are coming through. And that seems to be between a rock and a hard place whereby residual CCG contracts or tenders have come to an end and they're catching us out that they want renewal, part because of non-recurrent money, part because of timing, but we have raised the concerns about the number of waivers that are coming through, and we've raised that with the officers that we need to really get on top of these issues in case something gets back to bite us. And the only other thing for information, just in terms of the head of audit opinion for this year on our overall governance arrangements, we've got limited assurance, which is not a concern because we're in a similar position as most ICBs in the infancies, but what we are looking at is a plan next year to get us to a significant or at least high standard, and the team are working on that for next year.
Thank you, Neil. Any questions or comments? Again, for noting. Claire, can we go to the Transformation Committee?
Yeah, thank you. So you can see we received an update on the Cheshire Merseyside wide transformation programme work and received assurance that progress is being made. We had a mid-year status report from John on the ICS digital and data strategy, looking at the alignment between sort of C&M wide and the place work. An update on the prioritisation framework which board previously signed off and how we're going to use that. Probably most interesting was the outline process for allocating the ICB's transformation programme funding. This has been previously allocated to 9 schemes on sort of a non-recurrent basis, but we've recently opened this up for a wider opportunity for a number of other schemes, projects, programmes, with a much more rigorous assessment and approach. So just to let board know, we've opened this up for Q3 and 4 this financial year and next financial year. So against a budget of a pot of 2.5 million for Q3 and 4, we've received bids of 9.1 million. So we're looking at how we filter and sort of the rigorous approach with that. And then for next financial year, against a pot of 5.04 million, we've had bids of 18.65 million. So there's a very rigorous process going on at the moment to review all the schemes and assess them against certain criteria. And then there'll be a session in late August, which Graham will chair, which will make the final funding decisions against that budget. And finally, just to say, we identified the 3 and 4 strategic commissioning priorities for this next year. Thank you.
Thank you, Claire. Any questions or comments for Claire?
They seem to get to their priorities very quickly, or that's how it... And I just wonder if there's any learning from us. We've been talking as a board, how do we actually, determine what our priorities are? I didn't know if there was any cross-referencing we could have done.
Yes, do you want to?
I thought it did feel slightly that we were presented with these priorities and I wasn't completely clear how they'd reached them. I have got a meeting with Andrew Bivvy, the Director of Specialist Commissioning, in the diary to talk through them. Having said that, they align with the things that our networks were working on in any case, and that our Directors of Transformation had already identified as a priority, so it didn't feel like a huge problem.
I think that's fine. It's not about the actual things, it's the process that went through, because we're still trying to formulate that. So, thank you.
I would say they haven't identified specific funding against them. These are improvement programmes without a budget.
I think also to say, I can chair, I mean, the SpecCon team have been working on these for a number of years. So I think, as Fiona said, they were sort of presented, so they weren't, it wasn't we've just decided on these priorities very quickly. They've been a long time coming. But I think, as Fiona said, that they're priorities that we would want to focus on for our population, so I think we're reasonably comfortable with it. Thank you.
But Erica's highlighting a really good challenge for us, isn't it? you know, how do we get to priorities in an engaged way quicker?
I mean, hopefully we'd use our prioritisation framework that we've signed off. So.
Thank you. Can I just, a couple of sentences perhaps on the key issue that's, I didn't understand how we were going to go forward on the key issue in terms of the digital data strategy mismatch, I think, between Cheshire and Merseyside in place. Is that what that says?
Assure alignment with the work going on in place and sort of the C&M-wide approach. I don't know if John, you want to...
Yeah, so in the overarching strategy, there's a clear ambition to standardise and do things at scale where appropriate. And what we just want to test is, we heard from Tony earlier around a specific care model in Halton, which needs a specific digital solution, no doubt. And I think it's just testing we've got the right balance between at-scale solutions and local innovation and local need.
Okay, so we're being proactive, there isn't a... Okay, good stuff. So we're noting that. Right, I think I've not been notified of any other business. I'll look to Matthew. Have I missed anything, Matthew? Closing comments. It's been we've had some really meaty items at the board today. Some really great conversation and discussion. It feels as though we're maturing at our board and we're getting into the work that we need to get into. So, thank you very much for your time and attention today. Members of the public, we have made that commitment to come in to speak to you immediately after this meeting. Graham, are you going to lead that engagement? I can't see our MP colleague, so maybe she's outside. But she's outside, great. Okay, so Graham, you lead that engagement. What time are we due back? Half. Say that again. 12:30. 12:30. Thanks. Thank you.